call the meeting to order. Everybody, welcome everybody that's here tonight. Has everybody had a chance to review the agenda? You wanna look at me? Yes.
We have an addition to the agenda,
Okay,
and it's an awards presentation.
under new business or where?
Yeah. That'd be fine.
Okay, awards presentation you say?
Yes.
Okay. Any other? Oh, another one too is, I'm down, under number 2, tax credits.
Should I be under new business?
Yes, under 2. First was the awards presentation, next was tax credits. Everybody got that? Any other additions or corrections? Do I have a motion to approve the agenda as presented with the additions?
I so move.
Do I have a second? It's been moved and seconded that we approve the agenda with the additions. Everybody in favor, raise your right hand. Motion carried. Consent agenda, does everybody agree with that? You had a chance to read the board minutes, special meeting minutes, Human Resources and Quality Committee.
What is that?
Do I have a motion to approve the,
I so move, we approve the consent agenda.
do I have a second?
I second it.
It's been moved and seconded, we approve the consent agenda. Everybody in favor, raise your right hand. Anybody?
I'm just abstaining because I wasn't here for the February meeting.
Okay, I understand. Any public comments?
No, sir.
Introduction of guests, come on, Colby Community College Nursing Program
Vicki, you wanna
guests.
introduce this?
So this is Stephanie Dodd.
Hello.
She is the nursing instructor, the clinical instructor for the LPN students that have been with us this year.
Hello, nice to
Hello.
meet you.
Well, as you will recall, Vicki was pretty instrumental in getting this program here, and it's exceeded our expectations, and we really appreciate the partnership, the collaboration. So, anything you want to say, Stephanie?
Just, it's been a wonderful experience for our students. Everybody's been very welcoming. We've had a lot of opportunities to do all the skills that we need to get, and I think we'd like to come back next year if you'll have us.
Well, you sure will.
Awesome, thank
You're
you.
welcome.
Okay, thank you.
And I want you to know what I've noticed about your students, they're very professional.
Thank you, thank you. Appreciate it.
And a lot of times in hospitals, maybe the nursing staff's not as embracing, but here, they really appreciate the nursing students as
Well,
well.
and they've
So
just-
hopefully they're learning.
They've been amazing,
From the
yeah.
experience.
We've had the opportunity, Jessica came over and taught a class for us over at the Norton campus, and all the nurses have been very helpful. They'll take the students under their wing and teach them and show them, and it's just been a great experience.
No, we appreciate it.
Thank you so much.
Stephanie,
Yes.
is your last name Dobbs?
Dodd, D-O-D-D.
Didi?
Yes, ma'am.
Because I know a lady by the name of
Oh,
Dobbs.
yeah, Dodd, yeah, thank you.
But we have a Dodds here too, so.
Yeah, no S, I'm just a Dodd. Nice to meet you.
Thank you.
February,
Hey Stan, Jessica Hawkins isn't really a guest, but she wanted to be on at the beginning to kind of talk about our program.
Okay. So Rex asked me, to visit a little bit about antibiotic stewardship, and one of the reasons why is that we get these alerts, and are we doing all of the things that we're supposed to be doing to be in compliance and to move forward? And we have worked pretty aggressively on antibiotic stewardship, so I provided you a couple things. One is something that looks like this, only I did it in black and white, it's, colored ink is premium. Yeah, so this is what your physicians signed about 18 months ago. Every one of them have a couple of these that have the toolkits in them, which those of you that have been on the board for a while have seen the toolkits. And they've been using those like viral prescriptions, watch and wait prescriptions, information about when antibiotics are appropriate and when they're not appropriate, all of those sorts of things. And we've been using those. And the next level, amongst some of the other things that we're working on, is a board commitment and a board support statement about what we're doing. And so I prepared one for you, and I'll give you a couple minutes here to look at that. And then I have some printed nice and with colored ink, anticipating that you'll feel that it's appropriate to sign. And I'll try to sit here and not be too excited while I wait. Do you have any questions for me about what's printed there, or what some of those things are, or what they mean? It's upholding the highest standard of care for our patients, which the board has very much embraced, so I made sure to include that in here. And what I've done is I've created a couple of them, so not everybody will be on the same one, but several of you can sign this one, and several of you can sign another one, and then Rex will post them up nice and neatly in different places in the building, so that our community knows that we are supporting antibiotic stewardship and the best possible care for them. From the board perspective, which is what the physicians have already been doing, and that's been working very, very well. And some of you that are being on maybe like the quality committee, maybe a little bit more involved in some of the activities that we're doing to promote antibiotic stewardship and the things that we're monitoring, but I'd be glad to have individual conversations with anybody about some of those things that we're working on and the great progress that we're making. So what do you think? Everybody okay about signing these? All right.
Yes, thanks for being aggressive.
Yes, thank you. All right, there's one there. So there's room for 3 of you to sign, and there's one here.
The data tracking that Jessica's done and reported to the quality group has been pretty impressive. I mean, everything is kept track of, and the incidents of,
I'll let you go ahead and sign this one too, just so that it's all
Oh,
filled out.
okay.
That's fine. Did everybody get to sign one? Stan, will you sign the bottom of that one? And we'll have 3 of them fully signed. I appreciate that. We do a lot of education and looking at evidence-based medicine, but I just want to give a lot of recognition that the physicians really have embraced it and worked really hard. I mean, it's a multidisciplinary group. It's not something that I'm doing by myself. It's something that changes the culture and will last forever in your facility.
but not just the culture. 2 years ago, when this wasn't in place for the docs, and we hadn't really talked about it much before then. In quality, certain things would show up in the quality reports every month about patients, and that was addressed, and it was this antibiotic stewardship that's making a difference. So I really appreciate that it was a problem-solving thing.
Yeah, well, I am excited to continue to work on it. I'm so excited. This is like tremendous. I'm gonna be the envy of all the other infection control people. This is a hard thing to achieve for people, you know, to put the time in and to understand the benefit and then to have the support. So you guys are the gold standard and I want you to know that. Thank you very much.
Thank you.
Thank you. Jessica. Yes. Did I? One more. Okay, and I'll get those to you in a couple days. We'll get 'em.
Yeah, I'm ready to go on.
You are, but I hope, do I have to follow Jess?
Well, you don't have to if you don't want to.
Maybe we should bounce around then. It's a tough act to follow. Financial report. So this, before we go any further, these are the LPNs that are here. And, I mean, just a friendly, happy group of people, and they're in visiting with patients. I mean, the patient experience has to be better just because they're in the building, I would think, so. Do a great job. So, they're from what? So you got, they're from, what'd you tell me, Norton, Joaquin?
We got Norton, Hill City, Waukene, St. Francis, Kansas, Logan, and Atwood.
Very good.
All right, well, again, thanks so much. It's a great relationship.
Thank you.
And Vicki, thanks for making it possible.
Oh, thank you for letting us do it.
So we did get, hopefully, the board had suggested we put patients first. So this is our new vision statement, so we rolled it out at our all-staff meetings earlier this month. And staff was excited. Of course, I don't know how to get it off.
I think it's an ongoing
It is.
lesson in
I
punctuation.
I look for hyphens in places or put them where I didn't know they were even supposed to be.
Bravo.
so.
I have a question.
You'll be the gold standard in
I
our.
will.
Can I ask a grammar, so we're focusing on like the well child visits, is it well dash child, well child, one word, well baby? How is that
If
written?
there's a noun after well child, it's hyphenated,
Okay. Always hyphenated.
always hyphenated, until,
Get your well child
not.
checkup. Yes. So if I write it as a well child checkup,
yes,
is a hyphen? Okay.
because checkup's a noun.
Person first thing. Because like I'm so glad she's never in Broomfield.
So we ended up, the hospital, primarily our nursing staff, received a milestone 10 achievement award because we're seeing our trends in certain areas going the right direction, so. Good job, Vicki and staff. Jess has been pretty involved in it as well, so. You've had the stats, so we have more areas turned to green this month than in previous months, but this is my first attempt to automate my, our spreadsheets. Let's see if it works. Okay, there we go, good. So admissions and acute days are up significantly to budget to last year, to our 5-year average. Lab, finally, they've been sort of hunkering right below the numbers we'd like to see, and they've shot over this month, so that's good. Nuclear med, or this should be ultrasound and CT scans are both up, and we'll talk about those later on in my CEO report a little bit. And let's see, MRIs, let's see, cardiac, I think we're off a little bit, but let's go through. And then that was actually supposed to be the emergency room in the outpatient services area. It doesn't line up right on my screen, so. Any questions on the stats? I have some sort of gremlin here. The outpatient services are up, actually up, you can tell. Yeah, okay. So the outpatient services are up actually about 3,000 visits or procedures over last year, so that should be up by 9%. So any questions on the stats? Numbers are continuing to be green and growing, so that's what we want, obviously. More providers, and you get more, you're having more new patient
More
charts coming,
referrals.
so more referrals, the hospitals
They
getting
drive
more full.
everything.
Yep, so, yeah, if you have any questions, if you look that over, you certainly call, but the encouraging thing is the majority of what we do here is ahead of budget, ahead of our meals we've served are up considerably as well, so. Let's see, financials. I mean, obviously our big issue remains accounts payable, so I think you saw in your aging account, Crystal paid down, what, 800 some thousand?
Yeah, 840-some thousand in March, was able to pay down. As of today, we are down to 948,000.
And this shouldn't sound too encouraging, at least we're under $1 million, so it's, and again, I think depending on how things maybe work out with our cost report, hopefully there'll be some money to do that with. Let's see, cash, that's off to, cash is obviously down from February 2018 and down considerably from January of 19. And when you see the cash flow report, you'll kind of see how that occurred. The financials for February, we actually had, when we ran this the first time, we ended up with a little bit of a loss. We had a $30,000 loss, and Crystal sent her numbers off to Lutz, and they looked things back over, and we ended up, there was an adjustment, I don't know if you want to describe it, but there was an adjustment that was made that allowed us to have a $102,000 profit.
It had to do with the restricted capital account, and it needs to be reported a different way, so that's what actually helped us.
So we had budgeted in February to have a $77,000 bottom line. We ended up at 102. We had a really good January, if you'll recall, and then February last year was pretty good as well. I mean, when you go through this, when we look at year-to-date, I think you get a kind of a better feel for the year that almost was. But our professional fees remain high, and they're about where they were in January as well. It's about $20,000 over February of last year, and about $30,000 over what we budgeted. So again, I mean, a lot of that's temp nurses, and hopefully we'll start seeing that go down since we're not using the docs of care. Do you have
Well,
what's in that number?
Yeah, some of that is like our ultrasounds, our MRI contract, all of those revenue producing
So if your stats are
areas,
up,
so,
you're gonna have more
yeah,
contract
so that's
purchases.
gonna raise this too.
We've got more surgery, so it's more CRNA costs as
Right.
well, so. So some of that's good, and this Senior Life Solutions obviously is in there, we budgeted for that, so. Other than that, operations, or profit from operations, $99,000. Expenses are well under budget. Under last year, of course, we had 3 less days of the month, and then I think it's 2%, if I remember correctly, over last February, so. So again, I think expenses have been controlled well, and you look at, we had $1 million bottom line, or revenue month, which is good. It's obviously a little less than February of 2018, and then less than January, but this is kind of, we need to be in this number every month. Let's see, year to date, our total operating expenses are about 4% over where they were last year, year to date. And but we're about 1% over what we budgeted. And all of it is right here in professional fees. You can see we're $300,000 over budget, and we're about $350,000 over last year. So again, volume related, some of it. Senior Life Solutions is a big piece from last year that we didn't have. So, but our revenue, on the positive side, our revenue is about $1.5 million over where it was February of 2018. Running well over budget, about $1.1 million over budget. Our deductions for the revenue are up as well, so up considerably. So we made more revenue, and then we have to write more off. So we wrote off about $680,000 more than we had the year before. Of that, $1.5 million, you're going to write more off. So I think we do a really good job of trying to get our charges where they need to be, but that is kind of the way the game works. So anything you want to add about write-offs or anything? So anyhow, total operating revenue $11,400,000, so about $700,000 over last year at the same that's our book revenue after we've had these deductions
Yeah.
from revenue. But again, you've got, certainly you've got provision for uncollected accounts over here, so there's other things that go into that. But, yeah, if this number had been to budget, the professional fee number, and again, you have senior life services, which is, from talking to Tracy, I don't know, you want to talk about kind of the report she gave us yesterday?
Yeah, she's done 3 intakes, well, 2 this week, and then she has 1 for next week, which will bring them back to our full capacity. Which we are very profitable in that sector at 6, so to be at capacity at 10 gives us a really good, revenue stream in that field. So we're excited with the weather getting nicer, our elderly are more willing to come out, we shouldn't have as many sick days with our counselors, so we should also have more units plus more bodies. So things are going really well there.
Well, and I've heard Tracy talk at 2 venues recently, and she's definitely got a lot of passion. So she's out there, connecting, and this is kind of her calling and kind of her local mission work she does. So she's doing a really, really good job, as well as the rest of the team. So, any questions about the 11-month financials? Now, you won't have financials next month because we'll be closing out our books, so there won't be financials next month. So, and Chris will talk a little bit about that in a bit. The clinic, we'll just look at their month, year to date. So they, their numbers were down a little bit from January, but again, we had people missing. And I don't know, do you want to talk about any of your stats or anything? You have your report coming up, you can get it in. But we just have to remember that, we've had a lot of costs over there because we've added salaries, and the Logan Clinic was absorbed, and, so we're really building towards the future. And at the year end, some of these things will be squared up with the hospital. So the important number really to look at is, as a system, we have a $438,000 positive bottom line. We budgeted for $350,000, so the budget was pretty good. February was closer to $1 million, but those were against some of those grants coming in now. So I don't know, and the month of February budgeted for $31,000 bottom line, consolidated bottom line. We ended up at 9,000. So, and then last February was obviously better. January was a crackerjack month. So, any questions about the financials? The encouraging thing, stats are up across the board. The bottom line with the hospital and the clinics, $438,000. Expenses are in check and the revenues are growing. So, and as you would expect, our contractual adjustments are up too. So, pretty.
And that kind of goes along with the revenue being up.
That kind of goes along with the paying CMS back too.
Yes.
Yeah, we'll talk about that in a minute. So.
And we did a full year with SOS, right, now?
Almost, they opened in March. So, well, yeah, but not in financial.
Yeah, not
but
financial,
yes.
but
Yes.
I was thinking it was right.
Well, we'll do a business review next month, and we can, because a lot of the revenue you see is coming from there too, so. I thought there's a couple other things I would add. We spent a lot of money in the RAD room over the last year, so we wanted to make sure that we had all the numbers right, purchases, how much we financed, how much money we were fortunate to get from foundations. So we had total purchases of $415,000 in the RAD room, and that was the room itself, the mammography unit, the ICAD unit, and the RAD room is also a mobile unit. So we had $312,000 worth of donations, so we financed this amount of money. These are the payments we have and terms, and then when they're gonna be paid off. So 75% of the total radiology purchases for that department were covered through grants. So we've been able to obviously upgrade our technology and move it quite a ways forward as a result of that. So anyhow, I'd like to say I thought of this on my own, but this was Stan's idea. So to make sure you guys are aware of kind of what went in and what went out. So I don't need to do that. I think that's it on the financials. Unless you guys have anything else, any questions about if the board's okay, we can go on to order and then we'll come back and we'll have to pull up another screen
fine.
for the flow chart. Go ahead. if you
Oh,
want.
me?
Yeah.
Oh, I just have two, financial assistance, approvals for this month, which will end out our year. So as you can see, there's two patients there, and that's the total, so I just asked the board to approve those for those patients.
Do you wanna talk, you told me about one of these that we approved earlier that kinda
Yes,
turned
I
around.
was
You
gonna
wanna
kinda talk about that, but just, so, example, like, we had a patient that you guys approved probably about 3 or 4 months ago. And actually, Medicaid did retro her eligibility, so they came back and paid it, and it actually, which it'll show at the end of the year, but we, reversed that charity back on so that the account come out right, so, I mean, that's kinda
So that can't happen sometimes.
yeah, it can happen, yeah. And Medicaid, you never know when they're gonna retro or how that works, so, so there's those ins and outs all the time. So.
What do you mean by includes medical clinic if applicable?
Meaning sometimes the clinic doesn't have a balance
Oh.
at their, like they don't have a balance over there, they just have a balance here. And then sometimes they might have a balance at the clinic and here, and if they have two balances, we put that in the total of what the adjustment, or of what the charity will be.
So that's max right there.
Yes, that, and I believe those do not include, clinic this time.
So what would happen if
Just the amount would be raised by whatever they owe the clinic, it would be calculated in the calculation, which we, yeah, and then count. I send a letter to the patient, and then I send a copy of that letter over to the clinic, so they can make that adjustment on their side.
So there still might need to be adjustment made?
Well, after you approve this, then I make the adjustment, I don't make the adjustments till you approve this. If it included the clinic, then I would send the letter tomorrow, the copy, to the clinic, and then they would make their adjustments if it included a clinic amount.
So what she's asking, though, it could be more than this.
No,
There is no clinic
there's
charges
no
for this
clinic
month.
this time.
So you put in.
So you already know that.
Because you always.
Yes, I already know that.
So you just put that in?
I just put that just so that,
Put that in there to be informed.
yeah, just to cover that it could, cause I don't separate it out. I don't separate the clinic and the hospital, it goes all in one amount on the financial, or on the spreadsheet I do.
So that's a total.
Yes, that is the total.
Good deal, good job.
Okay, good, thank you.
Yes.
We'll need to vote on that.
Yes.
I move we approve the, financial assistance for these patients.
I have a second.
I'll second it.
Then move and second, we approve financial assistance for these two patients. Everybody in favor, raise your right hand.
So what does that bring our total to?
Well, glad you asked. So, of course, so that was what, 20, so before this approval, it was $79,372. So adding that amount will be about $100,000 total for the year. And that does not include this reverse yet, so it's be about 90 probably after that gets posted.
I think it was more than what we had last year, wasn't it?
I think last year was actually, I have to look, but it might be less. I don't know. I have to pull that number. Last year, yeah, I'll have to look.
Okay, I just handed out the consolidated, statement of cash flow for you guys. So we'll go through that really quick. So we go. Alright, so the cash flow obviously is your three main sections, your operating, your investing, and your financial activities. So that's just a snapshot of what you guys have in your hands. So this would be net income from both the clinic and the hospital. This would be your, payments to employees, gonna be salaries and benefits and everything, and then this other, where it says taxes and interest, your vendors and supplies, it's gonna be other operating expenses. But what I like to do is go a little deeper into the operating activities, so you can see kind of what makes up that number besides just those lump sums. So this first one that's circled here, this $133,000, That is a payment from our restricted funds from grant money, so it's not a true cash in, cash out, to purchase the mammography equipment. So that's a pretty large sum there, but it's a one-time purchase, so it's already occurring. This next number is something that we need to be looking at. This is a position of change. This isn't our total, it's an accounts receivable. That's how much our accounts receivable went up in February. So to give you, something to compare that to, your January number went up, accounts receivable went up by 24,000. February's grew by almost 150,000. So we are not working our ARs effectively as we would like to. We really struggled to kind of get some of that cash in the door in February. So that might have been providers being out. We had quite a few absences of getting that paperwork in. Really busy with cold and flu season. A lot of rehab was very full, so I can get some paperwork delayed there as well. HIM was down a person, so getting those things coded and in. We're short 2 days in February. But if we can focus on this cycle, obviously improves our overall operations. And that's something that Cody's working hard on. We've had a few meetings in the past month with department heads, HIM, different things, looking at some consultation work on how to improve this process as well, so we don't have these things. Obviously, accounts receivable means it's money out there for us to collect, so that's good. It's a good number. We just don't want our days being high, 'cause that's not cash in our hands if it's in AR. So being busier, having more providers, there's a reason accounts receivable goes up. We just gotta keep working that system, and that's what Cody is really working, focusing on. Rhonda, Crystal, department heads, HIM. This next number, accounts payable, as you can see, it also increased. But as Crystal foretold just a little bit ago, she was able to pay down a lot in March. So next month, we'll hopefully see this number be a decrease instead of our accounts payable growing as it grew in February. This third-party settlement was some adjustments that were made. We booked $115,000 about on a cost report change. We booked partial payment of that, and then we booked the credit amount from the clinic, so that offset that to the $74,000. So we have these two things that are kind of unique. They're not an every month thing. So if we had taken those numbers out, we would be at like about a negative 57. We don't really want a negative operating activities, but a debt of 57 is a lot better than 265. So I just wanted to show you guys a little bit more of what specifically we're looking at in that cash flow operations. And then, I'm trying to skip out of here. Crystal's gonna go into a little bit more detail on, on the ins and outs from kind of.
You want me to run it for you, you talk, or you?
Yeah, if you want to. This is a,
So get to the-
yeah. Okay, this is a spreadsheet that I thought I'd just kind of let you guys look at, to maybe help explain our cash balances and how we keep track of that on a daily basis. We list all of our deposits every day, which is here. And then if we get money here that should be for the clinic, because we have the same tax ID, that happens a lot, then we will show it as a PCMDC deposit going in and then a deduction coming out of here. You will also notice that, okay, like right here, this is where we paid some bills that day. We paid $93,000, so that comes out of our money. But we know every day where we are cash-wise. These here are like an EFT that is automatically taken out of our account that we have set up so they withdraw it automatically. And then some of our benefits are also done that way. So, it just helps us to know what we have, so we know where we are, what we can pay, what what's coming in.
You wanna
Then
see
at the
this every
bottom-
month?
I know it's hard to see, at the bottom it keeps track of the balance. If you go
Rex,
the other way.
Rex, there you go.
Okay, what I did here, this is what the hospital balance was at month end. Then we have a checking account for our tax funds that come in. I listed that there. Then PCMC, the clinic, they have a checking account. Well, it's not really a checking account, but money goes in and out there. So I listed that, and then, all of our petty cash funds between here and the clinic. So this balance right here, 870,000, comes back and balances on the financial. So I don't know if that helps you all to see what's going in and out. If you'd like to have this continue each month.
You don't have restricted funds in there, do you?
No, that's not listed, that's not one,
Okay.
but I can do that, I can
No,
list that.
that's all right, I just, that's great.
Right, cause I can't use, yeah, this is all what we can use. I don't know if this helps, or if you have any questions.
Now, the E were the deductions, F, yeah,
The
those
EFT.
column
Electron,
headings at the top,
Oh, at the headers?
yeah.
yeah. Okay, this is the check numbers when we go to
Okay.
do a check run. Voided or return checks, like if there's an error in the check run, we have to void. Or if we get a return check from someone that wrote a bad check, we put that there. And then this is all of the deductions, and then again, that, deposits that went to us instead of the clinic. And then our daily deposits, and then the balance.
Now, that's real money,
That's real money.
okay. Well, sometimes the numbers,
Yes,
I'm sorry.
revenue isn't truly cash, yeah.
so that's like a checking account balance. So if you can go to the bottom of that again, that's like the balance at the end of the month,
Right here.
right. Now, the numbers that are down there at the bottom, are those included where?
Okay, these are separate accounts that we
Separate
have.
accounts.
Yes.
Okay,
All of our tax money, we have to keep
In a
separate
different-
in a different account.
right,
And we can write checks out of there, and then we deposit what comes in via tax funds.
okay.
And then the clinic, they have a separate account that all of their money goes into, and that's what this is.
And then when it gets, I don't know what
And
amount,
then when I
they
need
decide
it-
to they transfer out of there, so they keep that balance
Right.
low.
If at payroll time, I see I don't have enough money, or if I need to pay bills, I don't have enough money, I go in electronically to the bank and transfer money into our account, so I can,
Okay, so the $817,000 thing
Yes.
there is the total of all of the real money
correct.
that is sitting in accounts and usable
That is correct,
at the end of the month.
at the end of the month.
Okay, I'm good. I understood that,
Mhm.
which is probably good.
So would you like for me to continue
Yes.
to do this
Yeah.
each month? Is there something more you would like to see added?
The only
This is
thing, Vicky,
exactly what I wanted, I
Okay.
had mentioned that, this is exactly.
the only thing, Vicky,
You
is
ask, we provide.
252,000.
Thank you.
That's tax money that we put aside for CMS payback.
Yes.
So
I knew we were keeping that.
basically, it's cash available, but we don't use it.
Well, we
To pay
can't
bills.
use it, we
Yeah.
Right,
know we're
until,
gonna have to do it.
right,
But that's all money.
it's all money.
It's all money.
Now, what are the restricted funds?
The restricted funds are what, we get like donations,
Okay.
or if we get a grant for something particular.
So it means it's restricted
They're
for a
already
specific
committed.
use.
Yes. Yes, and I can include, if you want, I can, make another line showing that, but that's not money that is usable.
But how great it's there.
That's very clear. Thank you for doing that.
You're welcome.
Good job.
Stan, would you explain to the audience that, what is the
job of the treasurer on the board.
You want to relate to that, Frankie?
I have it right here in front of me.
It'd be good. You're going to where I was trying to find it. but-
Okay, the treasurer shall cause to be kept accurate and complete accounts and books of the financial transactions of the hospital, and such records shall be available for public inspection at any reasonable time. Be responsible for ensuring that a budget has been prepared and presented to the board at least 10 days prior to any vote on the budget. Be bonded for the faithful discharge of his or her duties in an amount to be decided by the Phillips County Commission. The treasurer may delegate these responsibilities to the CFO, but shall remain responsible for regularly meeting with the CFO to review the financial records and make reasonable inquiry to ensure that the CFO is causing to be kept accurate and complete accounts and books of the financial transactions of the hospital, and that all expenditures have been made with the approval of the board as required by law. And I have been indivisible.
Yeah, you have.
And several of us have been asking for this, and she produced. Is that okay?
When did we change that? Did we change that, or was that always been that way?
That was it's been that way since the change to the bylaws, the last time, I think 2017, when there was.
Oh, okay. Because I was gonna say, it used to be the board, the treasurer was just responsible for the board funds.
Well, right, when you released facility, right, so so when the bylaws were updated,
Okay.
more robust explanation of the treasurer.
We didn't have any problem, I could keep up with that.
Is there any more questions on that?
If that isn't too much of a job or too much of a project to get that done every month,
No, we do it daily.
that there would be a good thing for the end of every month, so people could see where you're at.
We will continue that.
It's very
Is the board
transparent.
satisfied with that?
Yes, it's very transparent.
How about you, Tad?
Sure.
A question though,
Yes.
is there at a certain time of the month, do you really look and see what, if you have money available to pay the payables and so on?
Yes, we do this daily. We keep this up daily. When the deposit comes in, if I write checks, it gets recorded that day, so we know exactly where we are.
That's why when I walked in and asked her, she says, well, give me a minute.
Okay, good.
So if the money's not there, you might wait a couple of days to pay the bills or something?
Yes, if I don't, yes. And, if we get low, and need to pay some bills, I will pick a
Sure.
few that,
Pick and choose, right?
yeah.
All right.
But,
I might add is when you see that, she also has to look ahead for the next 10 days that payroll's
that's
coming.
what I was gonna add, yeah.
Yeah, so that's also, you don't kinda see that, but you gotta look ahead to the payroll part too.
No, you don't, because you don't need checks.
Okay, well, we will continue with this each month and go from there.
You're still up?
Yes, I'm still up.
That's all right, where you are, okay.
Okay, I'll try to give just a brief, synopsis here of where we are at year end. Of course, March 31 is our year end, so we're in the process of starting to get things together and start working on spreadsheets and so forth. We are working with LUTs. We're gonna try to limit what we do with them. We're gonna try to do most of it in-house if we can, and I've got Brenda Chance that I hired here a little while back. She's gonna help me with a lot of this too. The other part of our year end is part of the process is all the journal entries that I do need to be reviewed. And they're supposed to be reviewed by Rex, and he does that, he's reviewed all of those, signed off on them through February. So we've only got one more month for that to happen. As Rex said earlier, we won't have any March financials due to it being year end. It'll take a while to get through the process of year end and get all the worksheets completed. So, does anybody have any questions, or do you have anything to add, Rex or Cody?
And our goal is to do as much as we can in-house and limit the LUTs, the expense we have with LUTs, so,
Yeah.
but I think we're doing that, and you guys are doing a really good job.
I want to do as much as, because before, a lot of it was done by our previous company that we had. They would do a lot of, some of the spreadsheets, so this will be new to us on some of them, but we're gonna work through them and
Seems like you're adapting, just talk to me quite
we're
well.
trying. Yes, it's an exciting adventure, actually, so.
Hi, Rex.
It's worse, I have to try to figure your password out in front of everybody.
I have a little book with mine.
Any bets?
If you just used Hyrex, you'd never forget it.
Good.
Good job. One in every crowd, right? Well, let's find, Tara sent it to us, so let's see
Any
where
other
it is.
questions?
No, good job.
Thank you.
Yes, you're welcome.
Even King did a dry run, so,
There you go.
right here.
Yeah.
Oh, you don't wanna get that,
Hmm?
you don't wanna get that internal cost report, that, we got, CMS a lot of money.
But it is what it is,
It
it's
is
an
what it is.
interim cost report.
So, and,
Not right there.
yeah. Okay, so you're gonna drive it? Let's do. All right, so the important thing to remember is this is interim. We are now gonna be doing this monthly, so it's exciting that we're gonna have an estimate and we're gonna know where we are kind of every month, but it will change, how we do things going forward a little bit. So we're gonna talk about that during this as well. So they're gonna look at our previous cost report closely, see what our rates were, see how things are trending, see, what our days in swing bed are, days in inpatient, outpatient, all of that gets factored in. We put the month's current financials in there. So we can't do the interim until those are closed out, so that's why it says on your agenda, if completed, because it always kind of, you have to have everything else done before you can plug it in. So currently where we're at with February financials is we're looking at an estimated payable to CMS of $328,000. What that comprises of is the clinic is setting at a receivable of $236,000. So their rates, basically CMS is saying are a little too low, we should have reimbursed you more, so we're gonna give you more money. The hospital, they're saying we paid you too much, you owe us money on things, we're gonna talk about why that happens as well. So when you take those two together, you get that $328,000 payable. And one thing to kind of think about too, just to put it out there, when we look at our financials each month, and we have the hospitals and the clinics, and they're separated, these adjustments, like when we did the cash flow, I told you we booked that one payment, and it was that negative 74,000 because it was 115 of the hospitals negative, but the clinic got a positive. We booked that as one thing. We don't separate it out under hospital and clinic, so we truly are one entity, one financial, but that's something to keep in mind when the clinics are going down a little bit lower. Their receivable is not booked on the clinic side specifically.
And you want more costs over there, right?
You want more cost because the reimbursement's higher, and that's why Medicare's paying us for them. Also, something to take into effect is we have not factored in any of those items that both Simon Johnson and Lutz have identified. So far, they're looking at it. We had Jeremy and Simon Johnson say he thought he saw about $150,000 swing, just his first crack at it. Lutz, when they're doing this interim cost report, they're seeing some things as well. And of course, Lutz has already created this template, so we're able to manipulate it, work with it, it's a spreadsheet. So then Simon Johnson won't need to do the interim, so that's where that kind of checks and balances is, you have Lutz doing the interim, and then Simon Johnson will also see their things, and, Simon Johnson and Lutz will talk together each month as well. So it's not like we're duplicating efforts, or one's doing one thing while the other's doing another thing, and they're not gonna jive at the end of the year, they're gonna be working together, and, yeah.
So Paul Baumart, who is with Lutz, he used to work for Sign Johnson, so he's well connected within the Sign Johnson organization. And when Sign Johnson came and presented, they would send their auditors and their cost report people out at the same time. So as they're completing the audit, they'll be able to make adjustments and maximize the cost report. So, I mean, I think this will be your worst case scenario, unless we have a really super profitable March. That could change things.
So, yeah, we aren't booking those things that might be a change, we're basing our tool, our estimates on the 2018 cost report as it stands, not as there might be other opportunities in there. The other neat thing with this estimator tool is, you're currently looking in your capital equipment, we talked about budgeting, a CT machine, we're able to plug kind of that in there, what would it look like going through the cost report in the RAD sector, what are their reimbursements, and we're really able to manipulate quite a bit of stuff on our end so that we can make some even better informed decisions on where to strategically place those
That'll be our
costs.
tool that we can use.
Yes, so I'm getting trained on how to do that, and it's I don't wanna say fun, but it's cool. So some of these factors, we changed our rates November 1st, our payable was growing at a higher rate, that's slowed down because of that rate change. Inpatient days are up about 28% right now. Our swing bed days are down 20%, so those are basically balancing each other out. So that's not causing a big swing in our payback or our receivable. Where we're seeing the big substantial payable coming from is our outpatient volume, and that's gonna be your labs, your radiology, your outpatient clinic, all of those things. We kind of budget and set our rates at an 80% cost to charge ratio, where they're saying our current cost to charge are at about 74%. So that's 6% difference is where that payback gets built from. In our outpatient volume, when Rex did our financials, we talked about them being up about 1.2 million over last year. That's great, revenue's up 25% in outpatient. Our expenses only went up 5%. We're cost reimbursed, we have to remember that. So Medicare's saying your expenses, your ratio is not there, so you owe some money there. Overall, we are at a 16% increase in our overall revenues and a 5% increase in our overall expenses. So that's what's creating our Medicare payback right there. Booking considerations. So as we're already closed out February, and then March we won't have a monthly financial report to you, we'll be closing out the year. We won't be doing anything differently there. How we have been doing it, and Crystal can correct me if I say this wrong, but is booking it once. Like once we actually get the cost report. You'll notice last year in your financials you had a like $952,000 bottom line, and then we had a bunch of adjustments in March, and we ended up with like a negative 200,000-ish. That's why. So one thing to consider now that we're running this monthly is we can book that estimate every month, so that we don't have this big swing of adjustments. We know it's gonna be coming, we know where it's at. We can conservatively, we don't have to book the exact like $328,000. We can say, well, we think there's gonna be some adjustments here, we know we're adding a service, or we're bringing a provider in that's gonna be more cost. So maybe we only wanna book $75,000 of it, or whatever. We can be strategic in that, but we wanna think about that. So that's something that we're gonna be looking at, changing how we book that, so we don't have this big wide variance when we close the year in and go into our audit financials, and that does cause confusion. Well, why when you gave your reports in February do you have this strong bottom line, and then when it goes to the audit, whoa, there's a big swing? Well, we don't book that until we get the cost report done at the end. Where now that we're doing it every month, we can better forecast, better strategically plan for that payable or receivable, whatever it might be.
Any questions for Tara?
I wish
wish somebody else would ask these questions, but just.
Is there a dash I missed?
Tell me what you mean by booking this adjustment monthly. What does that entail?
Okay, so at the end of the year, we do general journal entries where we have to manually put in, edits, I don't wanna say edits, that's not the right word, but, things like this that aren't regularly ran through our checking accounts. They're not created with an invoice, and they're not automatically in the system, we have to put them in. So when we would get our cost report done, we would get the number that, like, so last year, whatever we owed, we got that number, and we put it in to our expenses. We wrote the check out of the tax money and sent that money out. Well, if we know going forward that we're gonna have that $400,000 payable every month, we can kind of see it starts building, it's at 200,000, now it's at 250. Oh, our rates, we adjusted them, now we're at 175. We can start forecasting that in our financials, so we don't have this big dip in why were your revenues here, and then when you get your audited financials in the year end, they went down to here. It's
It's a much better way to forecast, so you don't have such a swing at year end,
Okay, so this is just an estimate,
an estimate.
and it's not, when you say book it, it means you're keeping track of it monthly?
Yes, we're putting it
Is that what that
into, yeah, we're
means?
sort of putting it in there, so when we're doing our monthly financials, it doesn't mean we paid it. It means that we're kind of reserving that's.
So if we're
gonna be an
estimating a
expense.
payable, then we're gonna take our we're going to net that out
We
of our
would actually
revenue.
book that in the financial.
Okay, I get that.
Kind of like a small business, if you're gonna pay, taxes at the end of the year, you might do a quarterly estimate and reserve that, so it's not this
Right.
big shock at the end of the year, same thing.
And this might be
I
kind
get
of
that.
silly, Vicki, but, I mean, are you familiar with an accrual?
Yeah,
that's
exactly where I was going.
Because it is completely different than the cash basis, and I know,
Yeah,
and that's where this comes from.
I think that's where you use the term booking, because booking is what you do in an accrual system. And when you book something, that doesn't necessarily mean that the money is there.
That's, you are right, that is
And-
correct.
And all you're doing is you're basically crediting the account because you're booking it. But it could be 60 days, 90 days before you actually get the money.
That's right.
And this will be a best guess until we get to the end of the year and we know what
Right.
it is. But it gives you as board members more confidence in the financials, that we're estimating or taking into that
And the
account
community as
every
well.
quarter
Because
anyway.
we get asked, by the county commissioners or the community, like, well, why, when you presented your financials in February, did they say this, and then we get the audit report, and it's way different. This is one of those reasons, because we have some very large year-end entries that historically we've always just done annually. Same with the tax credit, we book that once. That's something we can kind of forecast and know, and look at different things.
okay.
Well, and to add to that, I think, if I may, you can book something, let's say $32,000, and you think you're gonna get $32,000 from a revenue source in 60 days. But in the meantime, you may have an adjustment against that $32,000. Therefore, you have to make adjustments,
That's correct.
and that plays into the bottom line.
World of agriculture. Anybody else got any questions for Tara?
So in other words, probably there'll be another expense. How would you do, will you put an expense line in here, or how will you account for it on the financials?
It usually goes into the contractual adjustment,
So it'll be
whether it's
over.
gonna be a positive or a negative,
So it'll be
depending on.
this, yeah, so you will either net it, it'll be right here, so if it grows, it'll be because we owe more back. If it goes down, we'll be in a more favorable situation.
We
So
have
it'll
a
be either-
line item of the third-party settlement is where it goes.
I had a question on what that meant.
Go ahead, Vicki.
Well, third-party settlement.
Insurance.
That's usually, yeah, like,
That was our,
And
yeah,
I thought
they call it.
contractual adjustments was insurance.
it is.
Medicare is, yeah.
Blue Cross Blue
There's
Shield
thing.
would be.
There's Blue Cross, there's commercial insurance, contractuals, there's Medicaid contractuals, et cetera.
but third-party settlements was
That is
mentioned.
for the cost report.
They changed names
They
on
changed
these
names.
things
Yes.
between them. Ah.
Yes, that's the most confusing part. Crystal can contest to me saying all the time, but on the department one, it said this, now why am I, well, the consolidated name for all those is this.
Oh, okay.
Any more questions? Ready to move on? Credentialing committee? What do we got?
The credentialing committee met, and we only had one application to review, and it's a new appointment, and we definitely recommend privileges requested, and it is our very own Tim Seifert, our PA. So I go ahead and move that we grant the privileges that he requests.
Is there a second?
I second it.
Been moved. It's been moved and seconded that we approve Tim Seifert credentialing. Everybody in favor, raise your right hand. Motion carried. Quality committee.
We met yesterday on the 27th, and we got a report from Deb Hadley from Health Information Management, and they studied 21 inpatient charts. They reviewed them, and they all met the admission requirements, so that's kudos to our providers and everybody that's part of that team, because we're gonna get paid for those. The average stay for the inpatient was 3.2 days. They mentioned that we saw 105 ER people in February. Rex reported that Frankie is working on a compliance plan for the hospital, and that this plan should be completed in May, and the quality committee will see it, and then he's gonna bring it to
I think we
the.
can have that done by May.
Did you hear that, Frankie?
I always hear half of it.
Okay, well, let me start over. Rex reported that Frankie is working on a compliance plan for the hospital.
Okay.
And he says it's gonna be complete in May, and it will be presented to the quality committee in May, and it will also be brought to the board in May for explanation and approval.
Okay. All right.
Glad you made it back.
Yes, yeah, that was good timing.
All right, then Vicki reported to us under the nursing, and she trimlined a lot of their quality assurance topics, so there's not so much reputation. And she has incentives out for the time-sensitive emergencies such as stroke, heart, septic shock. She has incentives out to the staff. We've been doing really good, but she's encouraging even better timelines that we get to that stuff faster, so she's got incentives going for that. So, thank you for doing that. She's encouraging her staff to utilize the Avera system in the emergency room for all true emergencies in that room. You know, we're paying for it, and so she's requesting that it be used. She also reviews the respiratory therapy guidelines, which she and Marty have put together. And they're gonna be start to collect data, and that's gonna start on April 1st, and that's coming from Marty's RT department. And she also mentioned that Marty will participate in all our sleep studies. So thank you, Marty. It's talking about you. Okay, something else that was reviewed was for the year, different areas involving the swing bed, and it showed improvements in all areas, How awesome is that? We got a little report from Mildred Hadley about the X-ray department, and we found out what a great job they are doing in protecting our patients and themselves from radiation exposure when they're doing the test. And they did the studies, and it's 100%, they're 100% right where they need to be, so kudos to them. I learned new terminology from Mildred. She talked about the reports, the X-ray reports are being dropped. So, well, what's that mean? And she said, well, when the radiologist completes reading the X-ray, as soon as the report's done, it drops into the patient's
On a good
chart.
day, it drops.
Into the patient's chart. And so it's all computerized, but they're having some problems. But it's getting better, and it's a computer glitch, and she said they did 251 procedures, and of all those, only 16 of those had to be scanned. So it's getting better, so they're dropping better, and that's pretty great. And last but not least, we heard from Material Management, Rebecca Flores, and she's just doing a fantastic job, you guys. She has tools in place, and she's keeping back orders to a minimum, and she has our outdated items down to 1%. And the reason she can do so good there is because we changed our purchasing agents last year.
Or a distributor, yeah.
Our distributor. And so instead of having to buy cases of things, we can just buy single items, and so that's really good. Something else that she really helps us with is actually our purchasing power with Vizient. She tracks down good deals
Yeah,
for
our
us.
return on investment, we're part of the MSS network, and our ROI, usually you try to keep it at, 7 to 10%, our ROI is 30 to 1, so she's maximizing
Yeah,
our
she's been
MSS
doing
network. And that's best in class pricing, because we're getting St. Luke's pricing and Omaha Methodist pricing, so anytime we can order on an MSS contract, that's a good thing, and
So good job.
she's doing a really good job.
Good job, you guys. And that's my report.
Anybody got any more questions for Jane on this?
However, that's keeping our costs down, Jared, so I don't know.
Depends on which area you're keeping.
Exactly.
And some that's really good, we are costing.
I think one thing, if we got that template for that interim cost report, though, that's
Yeah,
gonna
it'll
tell
help
us
us.
a lot. Like we can do it every 6 months or after 6 months into it, we can do that there ourselves, and then we can know.
I think pharmacy costs are gonna go up anyhow, so that probably will take care of itself, so they continue to go up.
HR committee,
The HR committee met the last time on March 11th, and I do have one question that I just now noticed, Teresa. The meeting minutes that are in here are dated February 14th, and I'm just a little confused.
And I just didn't update the date at the top then.
Okay, so
It should be the,
those of you with your packet, if you would like to change the date to March 11th instead of February 14th at the top of your page. Because as I was reading through the notes, this is what happened this is what transpired on the March 11th meeting. I think it,
2019 too.
yeah, in 2019. Thank you for noticing that as well. As far as I know, we turned over the organizational chart updates, and those should be in place by now, and we just made a couple of slight adjustments of who reports to whom. As far as the CEO evaluation pilot project, I don't have any other further reports from Jesse, so I'm not quite sure where we're at with that, but I'm sure Jesse will share with us at an appropriate time. I did do some exploratory, and I did write to Cindy Samuelson at the Kansas Health Association for assistance in finding outside sources that can help us with future performance evaluations, whether it's a CEO performance evaluation or another leader in the hospital. And this is one copy that they sent me from a company out of Chicago. There are very few companies in America that actually provide healthcare facility evaluations to boards and to leadership. So there's one in Oregon, there's one in Chicago, there's one in Texas. This lady here, Cindy Samuelson, thought she would probably be best. And so this lady, Barbara, and I have been exchanging emails about the possibility of using them in the future. And we don't know yet what the cost would be, but she'll explore that when the time comes. That's all I have.
anybody got any more questions for Cricket on this? If not, we'll move on to operational reports. Revenue cycle update report. Cody, get on board.
I don't have a lot, I just wanted, as of today, after, our cash, was $896,153 estimated, and so that's about $32,000 a day that we're averaging. We only have one more business day, which is tomorrow. So, we're not up to that million goal, but, we're working hard. As I wanted to share the days in AR, this is, after ending February. Our days in AR went up 2 days from the previous month, which could be all the changes with Quadex and getting the CV, or preparing for, clinic and all that. But our discharge to payment went down 5 days, which from 38 to 33. Our bill to payment went down 3 days from 18 to 15, and our discharge to billed went down 2 days from 20 to 18. Just kind of the goals, the discharge to payment goal is 35, so we're below that. Our bill to payment goal is 20, we're below that by 5. And our discharge to billed, the goal's 15, so we're up 3 days, so my goal is to try to get that down to 15. So, also as far as revenue cycle meetings, we had two this month. As the revenue cycle, we were having, if you weren't aware, we were having monthly Cerner meetings, continuing from when we implemented to go over Cerner issues. We decided to incorporate that into our revenue cycle meetings. So the first Wednesday is a revenue cycle meeting. The third Wednesday is Cerner, the first part, and the second half is revenue cycle because a lot of things cross over from Cerner into the revenue cycle. So we had a lot of duplicate people on both, and there's only like maybe 3 people that weren't on the revenue cycle, so we kind of brought them in to do the first part so that we're not trying to consolidate the meetings that we're having into one so that we can save time for meetings. So I think the first one we had this last went well, so that's kind of the change, so we're just working on new processes. Anybody have any? And I'm working on year-end stuff, just making some entries, making sure what charges need entered and that kind of stuff, so busy time. So anybody have any questions?
I just have a comment from my little Beulah.
Oh,
And she just pointed out to me today, she said, look, they've already paid my February clinic bill. She said, this has never happened this quickly. So they are noticing. So good job.
thank you. Anybody have anything else? Thank you.
Thank you.
Cody's done a real good job catching up on the revenue cycle, getting our AR days down and all that. She's done a fabulous job for that.
Thank you.
Even though Rex don't think so, I do.
I just think there's
Thank
room
you.
for improvement, so. You're doing really good. I would like, before Rhonda starts, we had a provider meeting today, and I would say they've gotten progressively better, I think, but this was by far the best one. I mean, people were collaborating, they were joking, they were looking for solutions, they were talking about capabilities, they had things they could do here that they didn't know they could do, and how they could look forward, and Dr. Weisinger came over after the meeting with some ideas, so. I don't know, Stan was in our meeting, and if you ever want to come to one, I think you would really be encouraged by what you're seeing in the provider community that's been assembled here. It's really good, and Rhonda's doing a super job, and the agenda, we stayed on the agenda for the most part, and finished pretty much on time, so good job. It was really a good meeting.
We signed times and.
But if you went to a provider meeting prior to these, this year one was 100% turnaround of what the last one was that I was doing.
Well, we're glad you're there so you could see the improvement, so that was good, so.
No, it was a real entertaining.
Okay.
Well, we've seen in quality, and I'm not on that committee anymore, but in the quality meeting, it has really been impressive to have the providers tap into what are the best practice standards for those time-sensitive diagnoses. Dr. Ben was there a month ago, and already that has borne fruit in terms of a friendly competition to do better, to have better times on things like stroke and sepsis and heart problems. I mean, they really have bought into that the same way they bought into the antibiotic stewardship concept 18 months ago. I have really been impressed with the teamwork.
Well, it's teamwork, and there's a professional competitiveness
Yes.
that's kicked in here too, and I think that'll only bode well for the future as well. Did you share last meeting, or was that in a subcommittee meeting about kind of the competitiveness on the timing of one of the, you want to share?
That's for
quality,
incentive.
share the whole board?
It wasn't med staff.
Was it? You want to share the whole board?
Which part?
Well, just Dr. Weisinger, we thought we could do it in 2 hours and.
Well, Ben wanted to set it at 2 hours, so, CMS says 3, Heart and Stroke would like us to do 1 hour for door to antibiotics and sepsis. And so, with the 2 hours, that's what we all decided on, and right after we voted on 2 hours, Dr. Weisinger and one of our traveling nurses got the antibiotics in 1 hour and 2 minutes, I believe.
Yes.
And so I went to the nurse's station and I high-fived him, and Dr. Ben was like, "Oh, what's going on?" And so we told him, he was like, "Oh, I'm gonna beat that." And then Tim was excited. He was like, "Oh, I can get a lot less than that." And I think a week later, him and Ashley Delaney got antibiotics in on 51 or 52 minutes. So they shaved it off even more. And Tim says, "Oh, I can get much less than that." So we've got a real competition going here. But yeah, we're doing that with it's not just sepsis, it'll be stroke, heart, anything we can do to improve our times. And we're also including lab with the sepsis and radiology with the heart and stroke.
Vicky's putting together a bulletin board, I think, aren't you?
Oh, yes, you know, as a school teacher, I know how to do bulletin boards, so.
It's fine.
Go ahead, Rich.
Rhonda, you're up.
Oh, Rhonda. I'm sorry.
Okay, no, I'll try to keep this short. We have a lot of things going on, but just kind of the bullet points that maybe, and in comment to that, I've been at the clinic probably 22 years, and this is probably the most cohesive medical staff that I have worked with, and that doesn't just happen. So, and it, you know, sometimes can be precarious at best, and so these meetings are extremely important, and they don't have a lot of time to sit down and chat and do one-on-ones. I mean, it's just busy, and they're busy, and so it's really fun to watch that camaraderie, and they really all respect each other and everybody's opinion, and they start out over here and they end up here, and it's just truly a blessing.
It was last meeting, we had 2 slots open, I think weekends or something, and Dr. Weisinger or Tim, one turned to the other and said, "I think we can handle this, can't we?" And they did, and Jennifer Hammond stepped up. I mean, as fate would have it or whatever, we didn't have anybody covering Monday and Tuesday. Tim couldn't come, so Jennifer.
It's,
And,
I mean, the
that-
scheduling is.
So no docs who care, they stepped up and did it themselves and worked it out themselves.
Yeah, we had 2 providers out, and then one got sick, and of course, it was on the days that Tim isn't here, so it's just that you know, snowball effect, but everybody stepped up. It was a little stressful, but I think everybody survived. One of the things in my report that I was pretty pleased with was our actual patient count in February. Of course, it was a shorter month, and then I did have some providers that ended up with maybe not necessarily influenza, but with influenza-like symptoms. But we were at 638 compared to 565 in February of 2018, if you reflect on the Cerner piece, and then 648 in February of 2017. So we were only 10 patients down from 2 years ago, where we had paper charts and we were able to see patients, and you know, we hadn't went through a whole EMR and stuff, so very, very encouraging there. Our chronic care management is really doing good. We set some goals and parameters, kind of watched it, and it's a coordination between Lindsay Johnson and the nursing staff at the clinic, and they get together and make sure that we have billable time for those chronic care services. And it's not a huge revenue generator, but we know that those services are doing kind of a hand-holding with our Medicare patients, and then it's also helping get reimbursed for all those phone calls, because a lot of our chronic patients, you know, they are going to referral appointments, or they are needing refills, or they're having, you know, weekly labs or PT-INRs, and so it kind of helps a little bit when we can track this to, you know, maybe absorb some of that cost that nursing time is used for that we don't get reimbursed because it's not a clinic visit. But we were at 92% of the chronic care management patients, we were able to bill 92% of those. So it's difficult to bill 100% because some of them go south for the winter, or they're sick, or, there's just some factors in there, so it's really hard to get 100%. We also had another record high of 60 welcome to our practice cards being sent for February. And I had to go back to January of 2013 to find a greater influx of new patient visits. And I think that was actually when maybe Dr. Primeri closed his practice. I don't remember that exact timeline, but I know it was somewhere around in there. So pretty exciting statistics going there. Provider absences, we really only had 4.5 days in February. 4 of those were calling sick days. So that is always kind of a struggle because that means we're having to move patients, we're having to redirect, and it, it's just not necessarily a fun one. No locums again. Robin did take 63 hours of PTO in February, but Dr. Weisinger picked up that shift. So we didn't have to use any Lexicare, so that was really nice. Our accounts receivable at the clinic is sitting at $410,000. The difference is, I went back and looked at the medical manager piece of it because I thought, gosh darn it, why is that so high? The difference is when we were on medical manager, we had charge tickets. And so the charge tickets were sitting on a stack in Michaela's office. They were not in a computer system to be, so 146,000 or 147,000 of that is the detail, not final bill, and I'm learning a lot about all of this through CBO and through going on to that. And so when the providers see a patient, they automatically drop that charge. Where it used to be circled on a charge ticket, and that charge ticket would go into the daily stack for it to be posted. So it never showed up anywhere in the financial. So if you subtract that, we're right kind of where we always have been, so I'm not real worried about that. Like Cody said, we've been now almost a month on the CBO, and so I think outside of today when something didn't balance and the girls were extremely stressed, I think it's been going really, really well. It's been a real change, and Mandy and Brittany have stepped up to the plate tremendously. I did get some feedback a week or so ago from the CBO saying that it is going well, the communication's going great. We're doing some billing tweakings with the RHC, some little tricks that I probably learned along the way that I'm teaching them on how to collect more revenue, and so they've been very receptive to that. We've had some battles back and forth. I've had to, kind of prove it, get the proof is, in the data, but then they're always going to say, you know what, Rhonda, this looks great, we're gonna go ahead and do this. So that's been exciting, but it's not kind of we're the CBO, it's my way or the highway kind of type thing, so that's been nice. KHIN, we've been doing some work with KHIN, and I won't go really into that, but it's Kansas Health Information Network, and it's data from all of the hospitals in Kansas. The providers are going to be able to get on there, and if, Vicki, you've been down at Hayes Medical Center, and for some reason we didn't get those reports and you come in, the providers can go on this website and find that information and be able to maybe have more of a continuity of care than maybe we've had in the past. So it's only Kansas, though, it doesn't cross into Nebraska, but pretty excited about that. Tyler, I tell you what, he's our PR king. He read to the kids at the library. Now he got dinged by Tara's daughter, but
So I asked Ella, my little sassy 6-year-old, I was like, so you went to the library? Yep. So did you see Tyler? Yep. Was he a good reader? Nope. Well, what? He read Froggy, and he kept saying Fricky. He doesn't know how to read very well. Ella, did you have fun? Yeah, Tyler's cool.
Yeah.
Okay.
So, and I got a picture sent to me from somebody there, and he's sitting in the middle of all the kids, and he looks like a kid, and I told Kelsey at the hospice banquet, I said, you're going to have to be the mean parent. Because he is not going to be, if they decide to have kids, because he's not going to be, he's going to be the fun dad. But, no, he had a great time, and I think it went really well. And then tomorrow he is going to be doing the career fair, at the, 4-H building for the high school, students, so I think it's in the morning. And then, several of them served at the hospice banquet. I know Tim was there with his family. It was fun to meet his wife and daughters. So that was a real treat, and so I'm really proud of them for taking that time, because when you see and treat patients all day, I think the last thing sometimes you want to do is go out and see more people. I mean, it really, it truly is, so.
Their cinnamon rolls were pretty popular.
Yes, they were.
Yeah, I couldn't even afford them. It was like, I was got like a bin.
$125
Yeah,
a
Nancy said,
can,
buy one for the
cinnamon rolls.
clinic, and I'm like, I'm sorry, love you guys, but not that much. Yeah, it
Good
was.
thing I wasn't there, they'd have been 150.
I wished you would have been.
HIPSA update, I know I talked about this a couple months ago, and Michelle with Frank and Forbes' office has done a really great job of helping me kind of dig through all this muck and mud in there. And to make a long story short, I think somebody asked the question, it might have been Kelly at the time, why we are a geographic HIPSA instead of the low income. And because in our county, the way we're set up, the low income really wouldn't benefit us as much as a geographic. And I can go into, if anybody wants a copy of my report, feel free to come in and get it. But it's not going to change really how our score is ranked, but there's some money in the geographic piece that you won't get in the low income piece that we receive now. So that wasn't a good thing. But we're working to try to get some of those providers. They extended the area to a 30 to 40 mile radius. So I went ahead and sent back like Osborne, Red Cloud, some of those I did a little thing on Google and showed where that was 50 or 60 miles. And so I guess that's a judgment call on their part to see if they will cross those doctors off of our list. So the one Dr. Knox did was on there, and he's retired, so that is an official cross off because he is retired. But the other 4, I think that I sent 4 or 5, because I couldn't eliminate Smith Center, and I couldn't eliminate Norton or Alma, so they're going to have to stay on the list. So anyway, but vaccine program, we've given them 3 immunization sets. They all went well. No reactions. It's been great, and the providers are really on board with working on getting that wellness out in the community, and Dr. Weisinger and Kelly are going to go on Tadpole in April and do talk about the wellness and why it's important. Because Dr. Weisinger said what he's seeing in the emergency room is, they bring in their children in, and he's saying, who's your primary care? And it's like, oh, he's never sick. That's, it's not just for sick. I mean, you really need to have those annual wellness visits. And, the school physical is a quick, down and dirty, but it is not a thorough physical. And with some of the healthcare challenge, or healthcare incentives, a lot of the annual wellness visits and well child visits are now paid at 100% through their insurance carrier. So that's kind of one of our initiatives, and I'll probably be reporting on that in quality. I'm having Nancy do some PACE forms and checks on that. So.
And Dr. Weisinger came and talked to me today about doing some marketing around that, and I didn't realize all the things they cover, and as a mom I should. Obviously I'm not taking my kids for these checkups, sizable baby ones, but they cover texting and driving, early drug and alcohol prevention, depression in teens, peer pressure. I mean, there's so much that you don't even think about them covering that we know are issues our teens
Social
are having
media,
to deal with, and our preteens. And I didn't even know that was something that was covered in this visit, so I learned something today that hopefully we can educate our community on.
Karen's going to help kind of get a brochure out that we can maybe hand to parents when they bring their kids in with a sick child to say how important. And then the other thing that to get this going, we do school physicals because of course the school buses those kids to the school, and it's a really benefit for both. But what we're going to do is try to touch all the parents of those children and credit that, the money they pay for the school physical be credited toward an annual wellness visit, a well child visit, if they bring their child in at a later date. So we can try to, and with the immunizations, we can be a one-stop shop. So I'm kind of excited about all that. a lot going on. Any questions?
No questions for Rhonda?
Good job, Rhonda.
Good job. Rex?
That was hard to follow you as Jessica. Christmas. Before I get started, we have drawings every quarter, people that attend all staff meetings. So we're doing all staff meetings every other month. So we had one in January and we had another one in March. So we do drawings for the people that attended the March meeting, and then we'll do January and March for PTO, which is very popular, so they will get time to pay.
Yeah, oh, please.
So if you guys would mind helping us draw names again, they think it's more secure when the board does it. You wanna? So, yeah, so this is for the monthly drawings, and where's the list of things? Here,
I don't know.
a $10 gift certificates to Subway, movie passes for 2, gift card to the bakery, cafeteria meals a week's worth, and 2 mystery prizes. So anyhow, we have hospital t-shirts they can trade their gift in for t-shirts.
Okay, Destiny.
This is where they get the
Yeah.
Subway.
Kevin Wilson. Let me know when to.
2 movie passes.
Vicky Gibbs.
Yeah, buddy.
Way to go, Vicky.
I already got plans.
Ready to share.
Oh, boy.
One little piece of paper here.
One little piece.
One little tiny piece.
Tim S.
Tim?
Oh, for heaven's sakes, well,
What's he getting? Movie pass.
Next,
a movie pass.
$10 gift card to the bakery.
Joyce. What's her? I can't read her last name. Nurse Hanner.
Hair,
Hair.
H-A-A-R-E-R.
Yep, yeah.
Okay, 1 week's worth of free hospital cafeteria meals.
This is one people really want. Seriously. Second only coffee with the CEO.
Jessica Stewart. And
One more.
one more.
Jessica Stewart won that?
Ooh,
I don't know, I didn't see, just shook it off.
Robin Burrell.
Oh, Robin Burwell?
Robin Burwell, good for her.
I think it's only wrong,
Is that
yeah.
Okay,
That everybody?
Mystery
2
prize.
mystery prizes.
Oh.
They didn't draw my name, did they?
No, not yet.
You had the opportunity to shove your name in there and you opted not to.
Nope. Ladonna Hilburn.
This is the last one?
Yeah. Amanda.
Surely have more than one Amanda.
No.
think so.
So now's it the
Now the
PPO.
PPO.
Hey, hold it, make sure, and then you gotta move it all around. These are people that attended January.
I thought we did that.
Oh my.
Amanda who? Oh,
It's empty, right?
Oh, and
yes,
housekeeping?
ma'am.
She wins everything.
I'm not sure how good this, we have to
She
dig
puts the
down
name
in.
in a lot of times, that's what.
Okay, we have to like dig down in, it's kinda hard to spread them around.
You better pick it up.
So this is for 2 hours of PTO? Or what?
8 hours?
No, let's start with the little one.
Oh, the 4 hours.
Okay, 4 hours.
Emily Whitney.
I got it. High price people. And nursing problems.
Tam Taylor.
Okay, one more.
This is for the 8 hours?
No, there's
This
one
is
more
for last-
4.
Tara.
Oh, Tara.
Okay, this is for the, and then last one's for 8 hours.
Gotta make it
Yes.
maternity leave.
Okay.
Out of that bucket.
Tracy Sanson.
Oh, wow.
That won't work.
Yeah.
Oh, she is.
Yeah, that doesn't work.
I'll give her a t-shirt.
That's not nearly.
I know. She won't see it that way either. I'll talk to Rhonda and see if her boss will give her 8 hours PTO.
Wendy Keith.
Okay.
I'll buy her a Sonic, how's that?
There you go.
Okay, they got
so we had two all-staff meetings, March 19th and 21st. And I think we had 39 people attend those meetings, but we're taking the show on the road. So we go to, I go to PT and present there, and then we go to the provider meeting and present there, and then we go to the nursing staff meeting. So that way, you know, our numbers are actually down, but I think we're reaching more people, so. Some of you have been sort of concerned, I think, as board members about our laundry expenses, and so they had jumped quite a bit. We had Ameritex here, that's our vendor from Nebraska, Grand Island. And so I think we're going to be able to at least get our laundry costs back to about half again as much as we had been paying. So we're waiting for their report to come back, but we're looking at our towel sizes and maybe having laundry, some of our EBS stuff done in-house with our on-site washing and drying machine. So we'll have a report next month to present, but that's a cost that even though costs are important, I think that's a cost. We're not gonna waste money either, so we need to get that back in line. So, this is incredibly good news, but, so we're part of the Great Plains Health Alliance Insurance Alliance, or hospitals that are part of the Health Insurance Alliance. And we've always been, if they look at insurance ratings, and we've always been over 1, which means our organization costs the alliance more than we're benefiting the alliance. And so I think we had 3 of the top 5 highest expensed employees here in our organization. Well, one of those has recently left, and the impact that'll have on the alliance is that's a $500,000 savings to the alliance. So I got a call. So Daryl Phillips, who does our benefits, and you guys who met Daryl, he called, and we've been talking about this for a while anyhow. But the alliance decided this former employee, they would end up paying their benefits going forward, and then their COBRA benefits, but we would do it under the Affordable Care Act, and then provide another incentive for her to sign a document, which she's willing to do. But what that does is save the association $500,000. It'll go to our personal hospitals experience factor, and so now we're at a 0.8 now. So our health insurance should go down quite a bit when Daryl comes later. I guess it'll be here in probably May or June. So, and yeah, that's really good news. And I told the alliance that we could certainly, it was our employee, and they said, no, this is part of being in the alliance. So it was no cost to us, any of the extra cost of getting her on the other plan or providing the incentive to sign the document. So I think the total cost of the association was $24,000, and there was a $500,000 savings to the insurance alliance. So as Daryl had said, that's pretty much a no-brainer. So anyway, we met with the banking community, and they extended a line of credit. So what is it, $300,000 now?
Yeah, we're at 300, we used 300, we have 300 left.
I would say I had Cody, Crystal, Tara went, and the bankers said that was by far the best presentation they've seen, and they're very confident of the numbers and where we're going. So they were very complimentary of the team I brought, so they did a super job. We did bring in an individual to look at our registration area, and so next month we'll share that with you. But we do have a layout, so we would get rid of our nurses station, and we would have registration of, I don't know, maybe we can look at it later, but basically there'd be 3 stations over by the wall. So we'd have high walls, we'd have low walls, so we could see people, but actually people that are sitting down, you would not be able to see them. So I know we went through all of this I think we were thinking it'd be probably $40,000 or more for the stations, and it's $3,500 a station. But Stan brought up, we have some talented people who joined our maintenance crew, so we'll see if they can maybe do it. But I thought that was terribly encouraging that it was really much less than we thought. And if we move to another building, we can take the stuff with us. So anyhow, so that's good, and that would take care of some of the issues we've been dealing with. Our PFAC fundraiser, the Funds for Signs, how much did that raise? Do you have the latest number?
I don't have the latest, but
Well, Crystal does. Crystal?
that'd be great.
$1,861.
See, you still got it. You said you couldn't remember numbers. That was spot on perfect. $1,861. So anyhow, so we actually, we're about, what, how much or short are we on the signs?
Should be like 1,300 or something like that.
So,
I don't remember the exact number. But we serve the same amount of people as the soup supper. So.
well, we had a
I think
business.
we have a core group of supporters in the
Right.
community, and I love that.
We had a business person's breakfast earlier this week, and the individual that was there said, you know, she heard a lot of positive things about it. It's getting people inside the doors that normally aren't inside the doors. Plus, they're seeing our organization work together as a team to do this in PFAC, and they really encourage us to keep doing it, so, anyhow. So thank you for pulling that off.
And they were real impressed with our host sitting at the table as they welcome people.
Exactly. Mr. Beam raised his game, and Tad, he was there too, so great job.
Well, Tad and I had to work together for, and
We
we,
had business formal and business casual going.
actually, we got along, believe it or not.
So we appreciate
We were
it.
gonna split it 50-50.
Oh, were you?
And I said, well, I'd take 60-40,
60.
and he'd have to take all the checks.
Exactly. Sounds like a deal. Well, thank you guys in the PFAC committee, they did a great job. Jennifer Dodge and kinda heading it up too. We made 2 county commissioner meetings in, March on the 11th and the 18th, so we did, the last one, we talked kind of about what they would like to see in their hospital and kind of involved them in the strategic planning process, so I thought, they had some really good ideas. In fact, they want to come look at our systems and our facility and get
Gee whiz, I usually spill everything.
So we talked last meeting, the Cole Foundation had decided they were going to we're going to use their funds elsewhere and not fund our student loan repayment program. Well, the Hanson Foundation has stepped up and funded that, so that's really good news as well. That's $24,000 a quarter that we were going to either have to come up with, or we were gonna have to tell the providers that we just couldn't do it. So we really, really, really appreciate Brian Stockman and the board stepping up and helping us out that way, so we will certainly let them know that. Respiratory therapy, let's see, we've got Marty sitting back there. Well, Marty generated in, from February 18th to March 29th, he generated $11,657 in claims. He's got all this stuff up and running, he's down the hallways, he's picking up trays in the patient rooms, we've got a picture of him doing that, so not only is he a good addition, but I think you'll see as we start sharing the financials with you, it was a great business decision as well, so. And we did get a grant. We ended up getting a grant from the Morgan Foundation for $39,926 to assist with respiratory equipment. And we will need, that'll require matching funds that we'll bring to you next board meeting. But we're gonna wait because I think Marty and I had a little conversation in the hallway, but hopefully we can get our PFT machine down so we won't have to ask for as much funding, which would require obviously less match. So we'll have that all put together next board meeting for you. But the encouraging thing, I mean, the Morgan Foundation stepped up and they're helping us with that, so we really appreciate it. And that was Dennis Miller was involved in that one and really kind of came forward and said, is there a program we can help with? And obviously it's a pretty important program for us. We did get our Kansas license, so those of you who were worried about that, we were worried because we hadn't seen it, and so it's here now, so that's good. And Cammie did it on her own for the first time, so she did a good job. We had Next Gen Summer Internship Program. I think we had 14 applicants last year. We have 15 this year. So they're going to kind of screen them out next week, and then we'll start interviews the following week, and then second week in April we'll make our selections. We're going to go with 4 half-time internships, so we can include as many people as we can. So it remains really popular, and Nick Poles allowed us to have an extra slot, so that was helpful as well. So. Tara talked about a CT scanner, so we're going to put that proposal together and we'll present that hopefully at the next board meeting. Great, Vizient has what they call these group buys, and so if you can sync up a capital equipment purchase with a group buy, you can save quite a bit of money. And I know when I worked for that other company, we were able to sync up a group buy for one of their hospitals on a CT scanner, and we saved $60,000 just by buying it within that 3-month window. And so they do have a group buy and for Siemens equipment, and so 2 years ago this equipment was about $600,000. With the group buy and with technology changing, it's down to $290,000, I believe. So we're paying about $77,000 on our old CT scanner every year on a service agreement, so we would have the advantage of not having to do that in year one, and going forward, the service agreements are $44,000. So Tara's in the process of putting a business plan together, and the other issue we're gonna run into is our CT scanner probably has one more year of service agreement where the tube is covered. And if the tube's not covered and the tube goes down, it's $250,000. So that will be factored into it as well. So, but this CT scan, we're going to double check and make sure it's what the providers want, but it would do DEXA scan, and then we also get an ultrasound machine as well. So it takes care of three primary concerns of our providers. I think it's 360 is total. So we did talk to Vizient, and they were able to extend the group I for another month until we could get everything put together, and then we talked to Siemens, and they will extend the pricing too. So anyhow, yes.
Also the weight limit thing, so that we wouldn't
Oh,
have to
yeah.
transfer patients out that were under the weight limit.
We could do a lot more procedures here than we were able to, and you're right, it was a bigger table, bigger unit, so. And I think a quarter of the amount of radiation, so it's a really safe machine too, so. Anyhow, be ready for your April board meeting, and hopefully we can build a business case, and then Tara's also working with Lutz to see what the cost report implications are as well, so we can factor that in, so. Let's see here. Kurt Erickson room, we'll dedicate this room in May, so we're trying to get a picture from the family. And then Mr. Bogey's helping us with that, so we'll plan on doing that in May. We're really short, we're short a dietary cook, and we're short a person in lab, so we're recruiting those two positions. The CEO and COO for Kearney Regional Medical Center and their outreach person would like to come down and meet with the board again. They have some ideas of things they would like to work together on. And we made a trip up there, last week, and there's good chemistry, so we'll.
It's nice they wanna come back.
Yeah, they haven't forgotten our work.
We had some good story time before the meeting started.
So they'll be back, and they're just good people, and they're growing like crazy. They actually are gaining a lot of employees from CHI. I think they got their whole OB department has moved over to Kearney Regional, so they're growing and growing quickly.
They started delivering babies 2 years ago, and they now deliver more than half the babies in Kearney. Just think about that, like, that's, and I asked their business development person, I said, did you plan on that? She said, well, yeah, we thought, we're 100 over our projections. You were very aggressive on, we said, well, we recruited the best from them, and we knew we could do it, and I was blown away, but that's impressive.
So they'll be back and visit with us, and we'll talk tax credits here in a little bit. We are gonna have Lutz come out and do an HIM, Health Information Management System audit. We seem to have friction points kind of with paperwork flows and just, how things are scanned in. So they're gonna come out and spend a day here, and the providers, they'll meet with the providers, and maybe we can make a few process enhancements and make things easier for everybody, and help revenue cycle as well. So I had a meeting with, a telephone conversation with Mr. Herman from Hayes Med, and he also would like to visit and come on his tour. So he said he would work that in his schedule and try to give us some dates where he could come out and meet with us as well. So he and I needed to have some conversations about mammography and some things we were hearing. So I think we've got everything worked out, and they're going to encourage people to use our mammography machine. So or at least that's how the conversation ended. And then I think the only other thing that's major is we have a Google Vault issue we're working through. Frankie's helping us work through, but I just, we don't want any surprises for the board. And we will be transparent. I think maximum worst case scenario exposure is what, $18,000-$20,000? Unfortunately, Google, I guess, was growing quickly as well, and they've been sending invoices to us, to a guy named Frank, who's no longer here and hasn't been here since 2015. So we're.
They returned actually to them.
And they said, well, we have internal credit memos. Well, we don't really, that's an internal one. We needed invoices to pay off of. So we're in the process of determining if we're actually talking to Google, which is kind of important. And thankfully there's LinkedIn, because you can at least connect with people higher up in Google. And so I think we're working through that, but some of our old emails have been locked down. So we're in the process of working through that. So anyway, think Stephen's done a really good job, Crystal's been involved, Frankie's involved, so anyhow, we'll give you an update at the next board meeting on the little hospital battling Google, and see how that plays out.
David and Goliath story?
I guess. So any questions about anything? Not as busy as the clinic, but we've had, there's quite a bit going on here at your little hustle bustle hospital, so. Any questions? Okay.
The hospital does an excellent job with patients, I can vouch for that.
They do a really good job.
Clinic, the providers do too. Clinic, now that's different story. Well, I think you get too much and then
Rex kept telling me, what do you need, and I kept saying, more providers, more providers.
now you got it.
And look where we're at now,
Thanks for the slide.
So you,
it's exciting.
and you had a perfect presentation too.
Now I've got the extra slides sticking up in there. That's okay.
You were standing right there, should have you heard, right?
Right. All right, we obviously at our last board meeting went through the budget deeply, so this is gonna be very quick, I promise. Next slide. I thought this was funny, I wanted to have like the music playing, you can't touch this, da, 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 da. Just the only one that laughs, thank you, my generation. Okay, yes. Gonna hammer out the budget. Okay, so we have moved from the collaboration. Yes.
Yeah, we could have done that, but we were talking about it.
Okay, so you're hip like us. I knew it, okay. So we moved from the collaboration circle to the approval, and that's what we're hoping to gain from you guys tonight. And then starting April 1st, we will be executing it. So these have stayed the same position assumptions, and as was reported from the HR committee, some of those structural things are already kind of happening on where people are moving and reporting and how it's going. We have a meeting, is it this Friday on the behavioral health hospital grant that we can look into that? Yeah, tomorrow. On getting that position going, we saw contractual, services were still kind of high in the nursing, so we did budget for those 3 full-time nurses, so we can hopefully get those filled. We've already got the maintenance people in, so lots going there, but nothing different from the last time. The only thing that's gonna be different here in our major assumptions are these kind of bottom ones here. We inserted salary increases on an average of 2% throughout all the departments. And then we took your guys' direction of adding in that 1% salary increase for salary adjustments, but without knowing specifically where we were going to put that 1%, it was throwing off how it would flow through the cost report and how things would change with benefits. So we did not put that in there. We just know that we have that 1% that if financials are going well, if we want to tap into that to adjust some salaries, that 1% is in that bottom line, it's not in the budget. We obviously wouldn't spend it or use it if financials were not there to support doing that.
We thought we'd look at it 6 months in, right?
Yeah.
Right.
And we would already have had our cost report done, charge master and all that stuff. Same considerations that we did not put in, we're gonna talk about pulmonologists here in a little bit. And some other programs through there. Rex mentioned some dietary issues that we could do with consultations. We did an outpatient clinic type setting, but we did not budget for those. So the only difference, we did those consolidated budgets. We were here, talked about we had a $306,000 bottom line. We changed in total operating expenses, that's gonna be your salaries. And the only things that have changed, giving you a new bottom line of $167,587. So that's our only changes of those 3 highlighted areas, and that is the 2% salary adjustments. Capital equipment, no changes there. The only thing I will say, I had one board member come and kind of ask some questions about this, and like what were our plans, this $500,000 CT. Well, we talked about that already. We do have some plans of hopefully getting that at a much discounted rate. But we are working towards, getting these things that we know are starting to be dated out, that we need to be looking at, we need to be having for these new services. So no changes there since you last saw that. Once we do have an approved budget, just wanted to talk to you guys about kind of what the process is. So each of the department managers get a worksheet that shows where they're at that current time, their budget versus where they are at fiscally year to date and in monthly comparison. And then there's a worksheet report that we set percentages, so it's not necessarily a certain amount, but if there's a variance in there, then they need to report on why. Why are they below or above this threshold that is in there, so we can kind of keep on tap and make sure we're staying within our budget. And then with the strategic initiatives that we implement as well, we have a cross check there on, are those in line with our budgeting goals? Are we meeting those, and making sure that those are speaking to each other and in line. That is just a quick overview of the budget. I don't know if you guys wanna see that line a little bit more there, but we would need a vote tonight on approving the budget to be able to implement it on April 1st. Any questions on the budget, any specific items you wanna discuss? I know we dived really deep into it last time, so.
I have a question on that monthly reporting of the budget by the department managers. What's the estimate on how much time that takes them to do that?
On there, not much, it's kind of like a one pager, so you'll be able to see it. So only if there's a variance, well, on our end, I mean, Teresa's the one who kind of runs it and hands it out, and Crystal.
I
Crystal
run
runs
the reports.
She had the
Oh, I know.
I was just trying to figure out what that monthly process, time-wise, cost.
After the general ledger is closed for the month, then I can run these reports. And what it does, it will list if they're a revenue producing department, it will show their revenue and against the budget figures. It'll do the same for the expenses. And then I also run a detailed trial balance that shows every invoice that they get. They approve their invoices prior to, but this just shows the invoices as they are recorded in that department.
And if there's a discrepancy about how much time does it take them?
Well, they might have to, look at the justification of that, do they have, are revenue goals not being met, why, are their stats not where they need to be, were they down a person? It's just, having that conversation, it's really not usually a ton of work, it's more just having that conversation of, where are we at now, do we need to fix a process, then that's gonna be a time commitment there, or do we need to readjust something, or that is gonna be where the time is.
Okay, how's that work? You talk, who talks to the department heads about that?
Well, I think what the plans going forward, we'll have the reports out regularly. I mean, it's a good opportunity to catch things, obviously, if we have, because these people do know their departments and how they're run. It's a good opportunity, like Vicki, when she's running way over with expenses because of temp nurses, we can talk about it. What's the opportunity to fix that? And then also, if there's a department head that's just, like physical therapy, all year they've been way over on their revenue and their statistics. It's a good opportunity to highlight them and what they're doing. And so, we will have regular budget meetings monthly before board meetings so we can go through this. And it won't be a punity thing, but it helps us better understand what's going on.
They're doing better than
Okay,
being
so
projected.
so you're doing that, do you do that with each of the department heads?
Well, the first piece is we have to have the regular budget reports out. So we'll get this done and then they'll be out. And that's one of Crystal's goals going forward is every month they will be out and they'll be out at a certain time. And then we will have probably a week later, we'll have our budget meetings, which hopefully in the next week we have board meeting. We will have those meetings and we'll spend an hour, we'll bring in probably 3 departments that are below and maybe a couple, 3 that are above, and we'll just quickly go through it. But help us better understand what's happening in your department. How can we help you and help us so we can explain it to the board better? And it puts a little extra accountability in the process, but we want to celebrate, because you have some department heads that really are doing a good job, so it's a
Yes,
good
it's
opportunity to do that.
definitely.
And how can we help as administration if they are having struggles or problems?
I just was trying to understand the process.
Well, it
That
also
sounds
gives
good.
them an opportunity to look at all the invoices that are booked in their department,
Make sure
in
those are
case
right.
there's an accidental miscoding or something, and then we can make an adjustment at that time instead of waiting.
Monthly, which is
Yeah.
good.
So that's the plan going forward.
Yeah, and some of the hospitals have shared with us some of their worksheets that they send out that kind of walk them through and setting those goals and things. So we're gonna be tweaking this, I believe, for the coming year. He said it was one of Crystal's goals on beat it out, and now how can we, now that we're getting it out, how do we improve the whole process and flow so that it's truly beneficial for
It's
everybody?
been a 2-year work in progress, but I think we know this budget backwards and forwards, there are 800 line items of expenses and revenue. This will be the year to get it started and do it right.
Good. Thank you.
I move to approve the fiscal year 2020 budget.
Is there a second?
All second.
Been moved and seconded, we approve the 2020 budget. Everybody in favor, raise your right hand. Motion carried.
And again, these two ladies did an incredible job on this budget. I've been 20 years of doing this, and this is by far the best budget, work, effort that I've seen, and all the department heads were positively involved too, so super.
And I'm the one that came in with the extra questions for her, and when I left, I was excited.
Good, the treasurer was approved it then, didn't she?
I like to be able to answer questions, that's,
Rex helps also.
yes, it was definitely collaborative.
Guys came in and yes, no, yes, no. I didn't do much of it.
You don't hit the escape key.
I did fight for a bottom line though.
Yeah, you did.
Against a negative bottom line, I just can't do that.
Well, they fudged the numbers. It's
We don't,
probably gonna
there's
be.
no fudging of
No
numbers.
fudging, we don't
No.
fudge.
No.
Can I fight to not be the redheaded stepchild anymore?
Get your numbers up where they,
In May, you'll be the superstar. You'll be calling you in so we can celebrate.
all right, so going from budget, like I talked about, our strategic imperatives should match. Where we wanna put our money is where we're wanting to grow, focus, that sort of thing. So it's natural to, at the same time you're budgeting, to be setting your strategic plan. Just like our budget is our roadmap parameters, obviously it's not our set, the only thing we're gonna focus on, the only thing we're gonna do, but it gives us kind of that big picture and vision, as we're setting our budget, as we're looking at what services we wanna bring in, as we're discussing new ideas, and we're constantly receiving different proposals and different things, and it gives us kind of a back to, what did we hear from our board, from our community, from our staff, on what we wanna do. So quick review on 2018, we had 64 strategic imperatives plus 18 outpatient specialties that were identified as things to look into, to possibly implement. Some of these were things that we looked at and decided weren't feasible. Dialysis, I think, was one, or is one we're looking at this year that might be kind of that kind of criteria. So of those initiatives, we had 88% of those completed within the year, before year end of the actual calendar year. We had, of that 88%, 85% were implemented, done, we're still tracking, we're still working on those, I mean, they're stopped. But they were able to be kind of handed off, and they're within that department, and they don't need leadership council overseeing them all the time. 10% were decided that they weren't a good fit for our organization for whichever reason, and were removed. And 5% were tabled for next year, which would be this current year. Things like our career club, we're looking at this year now. And 12% were in progress. An example of that would be respiratory therapy. It was in progress of getting Marty here, but by December 31st, it was not completed. With our strategic plan, we want to make sure our core mission of being patient-centered excellence is at the forefront of all of our strategies. And then, no matter what your role is, if you're a board member, a staff member, any of that, that we want commitment to the plan's progress and the success to it. And don't we have awesome looking patients? We have our disaster drill patient, Cricket.
Oh my God, is that me?
And we have my great cute baby. You're the best patients. So our strategic pillars are comprised of 5 different areas of focus: our patients, our services, our people, our systems, and our community. So these are areas that we really wanna focus in on, and then each of these have their own metrics and goals and strategies and tactics within them to make sure we're meeting those. Collectively, those strategic pillars, those 5, should aim to do the following of increasing, recognizing, and setting us to be the best organization that we can be. As we go through them, we are in the process currently of setting up our goals and our metrics. Implementing a strategic plan isn't a small task. It requires a lot of input from everybody at both county health systems and also our community. We did the different listening tours with different community entities, staff, like I said, board, providers, kind of anywhere we could go in the last couple months we've been talking about it. We also assign accountability leaders to each task that will work on them. That's your list that you have there. You can see how we've prioritized already. That's our first step we sat through in leadership council. We talked about who's gonna take ownership of these and what priorities should they be. You will see there's a lot of red because we wanna do everything. We think everything's important. And so there's a lot of red on your sheet because people were passionate about making sure that we are implementing these. So from this, we'll be setting timelines so we know when we should be focusing on different things and when those should be handed off and set, keep going on the department level, and how we're gonna measure that. If it's adding a new service, how are we gonna measure if that was successful or not, or completed? If it's shortening clinic times, what is our goal there? If it's adding in a better quality metric, AIDIT maybe, how do we know if that was truly implemented and adhered? Is it every employee having it on their badge? Is it them being able to recite it if you walk down the hallway? How are we gonna measure and test those things? Our leadership council, they don't know this yet, but they'll also be reporting quarterly to leadership council on the status of theirs. So that we will have kind of a shared workbook that will look very similar to this, that they'll be updating their status. So we know if it's in progress, if it's stuck for some reason, they're waiting on an outside entity or force or financial ability to be able to do it, maybe we're waiting for some metric to be met. They'll let us know where they're at and we can start brainstorming on how can we all get involved and help. Because like we talked about, it's everybody's. So what are responsibilities? They are everybody's. To understand how they work together with our vision and mission of patient-centered excellence, how they work with the budget, how they work with our different departmental goals. Reading and discussing them as a leadership council, as a management team, as a board, discussing it with our staff at staff meetings, reading and discussing it again. It really does take a lot of ownership to be able to apply it to your everyday work and making sure that we have those goals in place and that everybody has their input on reaching those goals and reporting on those goals and that accountability being in place. So this year we went from, I think it was 64 to 87. So we are pretty aggressive there on the things we want to hit and meet. But if we have our budgeting process in place and we're measuring that monthly and we're looking at this and reporting on this to each other, we really should be set to hit those marks that we've set with our stat goals and our budget goals and our strategic goals for providing that level of care that we expect from our staff and to our patients. And it really took a lot of input, so I really wanted to thank you guys. You guys did a lot of planning and brainstorming on this, and a lot of our staff sat through multiple rounds of brainstorming, and it still requires 100% participation from the board level on down to make sure that we are gonna be able to meet 87 goals. We're already at the end of March, and we have a lot of work to do to get these up and going and met, but we're pretty confident we met last year's goals and we can do it again this year. Any questions on the strategic imperatives that you have there in front of you or about what we'll be doing with them?
I move we accept it.
It's been moved and seconded, we approve these, what do they call them?
Strategic imperatives.
Everybody in favor, or any discussion first on this? Everybody in favor, raise your right hand. Motion carried.
I think I gotta keep going
about it too.
Yeah. It's good, we have some personal experience on both ends. So we, and I think we've talked about this, I feel like to death, but you all have heard about it, except for maybe our newest board members. We have been offered a grant with the Heartland Health Alliance, to participate in a grant to get telemedicine services through Bryan Health. They are really one of the leaders, if not the leader, of telemedicine offerings in kind of the Midwest area. And so we would get about $50,000 worth of equipment. Our match is $5,500. We kind of want to talk about what that looks like, and some ways that would be applied throughout our systems. So a report came out actually last month from the American Health Association that really touched on the government's plans on expanding telehealth and telemedicine. There's a difference between those two words. Sat in a 4-hour webinar about this one. It was actually really interesting, but they really know that rural hospitals, that point of care and access has to have a component of telehealth in there. We've already seen a lot of regulation changing on the reimbursement rates on that. That's improved a lot since we first started looking at telemedicine 3 years ago, and had the Julius in here. And you see a lot of changes in the VA hospitals as well, and that's really where they're starting to make some major changes in access to telehealth. Some of the capabilities that telehealth brings us is our improved access to care, bringing specialists here without having to actually have them physically here. We can enhance our value-based care and patient interactions and offer substantial cost and time savings to both our facility and to our patients. Barriers, statutory and mandatory restrictions, they are improving, they still have a long way to go. The broadband connectivity in some areas, we do not have that issue. I did talk with Stephen and Kevin. Just like we have it with Avera, we already have gotten that in our hospital and our facility. And we have enough ports to be able to tap right into it if we need it, if we wanted to have a certain system that required extra versus kind of the regular iPad types. Cross-state licensures, Brian deals with that for us. It wouldn't have to be on our end, and they do have quite a few Kansas physicians and specialists on their thing, but they have obviously Nebraska and stuff as well.
So that would not be a cost to us?
No, not that part. And then the high cost of acquiring equipment, obviously, that's where this grant comes in. That helps remove that barrier here. So it is expensive equipment. There's just a quick snapshot of how much it's grown in less than 10 years. So, so I said see handout. I don't have a handout, but wanted to talk about one example of a system that we could use, and I'm going to let Maury talk about this a lot because we brainstormed for quite a while in his office about how this would look. I met with Melinda on the outpatient side and all of that. So, if we were to go with this grant and we wanted to bring in pulmonary and respiratory care, part of our grant would already cover up the site readiness engagement, the administration, data technology, the quality, the procedures, PR and marketing, credentialing, billing setup assistance, and HIM part. And engaging our medical staff in how it works, employee forums, subject matter presenters, all that stuff's part of the launch. With the different programs, there are different setup fees. So if we were to just bring in pulmonary, there would be a $4,900 startup fee, and that has them coming on site, training Marty on how to use the certain stuff, training Melinda on it, doing the network and firewall analysis, getting everything set up and installed, integrating and that sort of thing, because they do come on site to do this. If we were to do multiple, if we were to also bring in a rheumatologist at the same time, maybe a acute care type setting, some other ones as well, then they can do those at the same time, so you have a great reduction of the fee there. So you might have a $1,000 setup instead of the $4,900. The equipment, one cart would cover all of their programs, so we're not having to buy the multiple carts and do all of that. So that grant piece would cover it for kind of all of your programs. Cody and Crystal did a lot of work today on talking with them on how does this look for pulmonology, pricing, and that sort of thing. So with the pulmonologist, with respiratory care, there's two different programs. There would be our program with Marty. They would provide the medical directorship, which he is going to need. We looked at St. Francis's respiratory therapy model quite a bit when we set up ours. They were able to get a medical directorship out of the Platte Valley Medical Group, who provide a lot of our outpatient services. They are at capacity. They aren't able to provide that for us. So this would allow Marty to have that oversight for doing the PFTs, and it would include all of those PFT readings. Sleep study options would also be available under that for that. And we're still working on how does all of that charges work, and do you guys want to speak to that at all?
Yeah, we just got to do some investigation yet in regard to the physician side of this, because we will have to bill for the physician fee. And we've not done that before, so we've got to do Cody's got to do some investigation.
And then Marty, do you want to talk about kind of how that
We
would
got
work?
we got a bill for the,
Professional fee.
They will reassign benefits,
Oh, reassign their benefits.
which we don't.
That guarantees them a set rate. There's no bad debt, there's no nothing on there, and that's one of the things that's not good for us, because there is a certain amount of bad debt that goes along with any kind of collections of anything. And that's where we need to do our due diligence and make sure. Usually in contracts I've previously done, there's a certain amount, if we have to write off some, they'll help us. They'll take some of it too, so we're not eating all of everything, because we own all the risk, and so that's where we have to watch a
And so
little
that's what we're
bit.
still working on
Yep.
all of those. We want to make sure, as we do have the grant for the PFT equipment coming. Rhonda mentioned that just today they had to refer a PFT test out. They also had to refer a DEXA test out today, so things are kind of lining up on where things are going. And of course, that person went out getting DEXA decided to get a mammogram at that place too, darn it. So we really need for it to be able to do the respiratory therapy, especially that occupational health program, we have to be able to offer this sort of a medical oversight, and this program would allow for that. And then on the same system, the same pulmonologist, we could then offer an outpatient program that would go into that. Now, as I said, we're still having to look at how does this telemedicine reimbursement structure work, how does all of this happen? But the great thing about a program like pulmonology, dermatology not so much, let's look pulmonology, you get this cycle of referral and ancillary support. So a pulmonologist is going to be getting scans of the chest done. They're going to be getting lab work done. They're going to be doing all this other stuff that then those feed the revenue cycles. Those feed our ancillary services. They're going to our providers can refer to that pulmonologist. Our pulmonologists can refer to our providers. You start seeing this whole cycle. They're going to be ordering more sleep studies, that sort of thing. So when we're looking at telemedicine, we want to look at how can it support our current providers, our current medical staff, give them the services and support that we can't get here, like medical directorship over a program like PFT readings that, like I said, we got the equipment coming, we got the programs up and going, we're getting requests for them, we just can't do them yet. Or how can it bring in patients such as an outpatient clinic? We would not implement or start any of these until obviously we figured out that billing component, that financial component. We're not saying we're gonna be signing a contract tomorrow and getting pulmonology in our outpatient with Melinda set up next week. It's just that option is there to build on with the grant for this equipment. Another thing that really excited me, I am pretty passionate about telemedicine. I do think being rural, it's where we're gonna go. I always give the example of my mother, and I probably should sign some HIPAA stuff for her, but she has to go to a neurologist in Kearney quite often, and she can't drive up there. So it's taking time off work, it's taking her to those things. And I don't mind so much taking my own appointments if I have to go to the OB or something, because I can go shopping, I can go out to eat, it's kind of fun. My mom can't do that, and it wears her out just to get there. So it's kind of a pain. Don't tell her I said that, I love her obviously. But we went up and met with Kearney Regional, and they are our biggest provider of outpatient services. That's the Platte Valley Medical Group. So we were meeting with their CEO and their director of new business, and we started talking about this telemedicine thing that we were looking at and talking about what outpatient services could they provide. And there's a little hem-humming and like, oh, we don't really have any more specialists to send you guys. But Travis, their new program director, and I started talking, and Rex and Jennifer Dodds, and like, what can we do? What's here? They're also part of this Heartland Health Alliance. It's funny how things start coming together. And they see their outpatient models moving to a hybrid, where they're sending their specialists here maybe once a quarter, and then your follow-up tests are with that same provider, but via telemedicine. Or my mom is going and seeing their neurologist for her appointment, but then in Kearney, but then the follow-ups are from here via telemedicine. So when our biggest provider of outpatient care is saying they're going that direction with the same person or team, Ryan Health, that we're looking at, it really makes me feel that we're on the right track there. I always love when those things just start to collide. It's like, oh, you're talking to them, we're talking to them. You're our biggest provider of outpatient and you're wanting to go the telemedicine route as a hybrid. We're also looking at that. Our Senior Life Solutions team, I don't know if I'm allowed to say this, but I'm saying it. They already offer psych, obviously, through telemedicine, through the Zoom counseling. So they reached out to us last week and said, what is your interest in doing other telemedicine options, psychiatry and that sort of thing, through telemedicine? Because we're thinking about expanding it and not just doing Senior Life Solutions, but offering it. I said, well, that's coincidental because I had providers at the last provider meeting asked me if there was an option of using our psychiatrist through Senior Life Solutions for some of their patients. It's not an option right now, but it might be. We would have the technology already in place to be able to offer that if they were to bring that in. So there's a lot of usages of it. Obviously, I think pretty much any outpatient specialty you can think of, they have systems for also provider backup, if you need mid-level support. They have different models for inpatient use and that sort of thing. I don't know, Stan, did you want to talk a little bit about anything?
No, I think that if we'd had telemedicine with my wife here last week, I don't know whether I'd have to go to Lincoln or not.
It'd be not, and to have that kind of question out, if you could dial up and have that neurologist, have that pulmonologist with the rest for any of that, it is nice to be able to do some of those things. Especially if we have those built in with, like Kearney Regional, who do a lot of our referrals to and transfers for CHI or Hayes, or doing more of those, so.
Well, just to kind of further the conversation a little bit that we had with Kearney Regional, I mean, if we partner or have a partnership relationship, we don't wanna just be the partner that's there sucking from the bigger hospital, we wanna contribute. And, I mean, they were quite intrigued by Tara's expertise in telemedicine, because they really don't have that in Kearney Regional Medical Center. And then quite frankly, Jennifer Dodds is light years ahead of their patient experience person. So those are the two things we can offer, and I do think this opportunity with Brian Health, not only does it seem to kind of start putting the pieces together for us, you want a partnership, or we want a partnership with the best, and Brian Healthcare is the best, and Kearney Regional Medical Center realizes they're the best. So this Heartland Health Alliance, I think, provides great promise for the future if we look north for a relationship. So anyway.
I think one thing about this telemedicine is that they got an a la carte where it's one place and that's the only place it can be. With telemedicine, it can move around to patients' rooms and stuff.
Thank you. So there's a lot of opportunity. In order to take advantage of the grant, we would have to participate in at least one program like this. And this, obviously, the pulmonology program makes the most sense. They do have an emergency services or emergency room program that's less expensive than Avera, but you don't get the nursing piece to it. So I think you continue to build, and before we would bring any new services in here, we'll bring it to the board so you can look at the cost and see if you think it has utility and merit in the community. So, but in order to take advantage of the $48,000 grant, we have $5,000 worth of matching funds, right? And then we're gonna have an installation fees of $4,000 and something, or connectivity fees or something. And then we'd have to commit to the pulmonology program. So, but for that, you get the equipment, which is state of the art, leading edge again, I mean, Ryan Health wants to work with us, but they said there's 17, 15, 16 hospitals behind us that would definitely take advantage of the opportunity. I think Kearney Regional would if we would drop out too, so I don't think there's a doubt about
And
that.
like I said, we can get that installation per service decreased if we can do multiple at once too. So we'll aggressively look at, if we are going forward with this, okay, let's get Cody on, what charges make sense through telemedicine, where can we strategically place those, what feeds others, like I said, dermatology, we hear that a lot, let's get dermatology. Fortunately, in the telemedicine realm, that's gonna be a service you're providing to the community, you're not, it's gonna be a cost. But if we can find those ones, rheumatology, I didn't go to school for a reason, would be another one that would be really good, because it would feed labs and clinic visits and medication, all of that, so. We talked about, they do a pain clinic that the providers have also expressed some interest in, pain management. It helps, there's a lot of grants out there for opioids and those sort of things that we can maybe tie into with that, it would be something to explore. Because it gets a lot of exposure on our providers and things when they're having to prescribe and oversee those controlled substances. And if that provider happens to be gone, another provider has to carry it, that is a concern. So if we had an option of a pain management type model overseen, then that's something else to look into. The providers have requested some research into.
Another need that they don't have now or can't meet is, we really need, I think, another opportunity in the community is outpatient nutritional consultations. And we've had a difficulty doing that in-house with our current contract provider, because she's got 14 other hospitals. So they did say that would be something they would build. They thought there was some need for that in some communities as well. So that would be one that would make a lot of sense for us as well, so.
It would probably feed into our diabetic programs that are, so we're looking at those things that feed our in-house services too.
So it sounds like our docs have bought into this?
Yeah, they're very open to telemedicine. They're used to it with the Vera. It's in our honestly, our patients as well. I was surprised. I thought some of our older patients would struggle with the technology. You look at Senior Life Solutions, all of their psychiatry appointments are telemedicine. They're getting used to it. They're FaceTiming their grandkids. It's becoming the realm. But yes, when we did our strategic planning with the providers, we talked quite a bit about telemedicine opportunities. And maybe Tim can talk more about that. But I think they're pretty used to that concept.
It's what's coming of the future, whether you wanna accept it now or later, that is what's gonna happen. I mean, it's pretty well set in stone that you're not gonna have a specialty service at your door unless you do it through telemedicine for a lot of different things. And in order for rural hospitals to survive, you have to look at other ways to generate funds, and these are ways that you generate your revenue and labs and x-rays, and you hope that helps pay for the expenses of your telemed. Just like they was talking about rheumatology, they run a lot of specialty tests, blood work tests, and those are very expensive tests. And they run a lot of lab.
A lot of the risk is being reduced because you're getting the equipment for $5,000 basically, so that would be $50,000.
Okay, the equipment is the $5,000, and then connecting it
Yeah.
is.
It's in your handout that they just came around. You can walk through that, like, now that you have it. So if you look at the back of your front cover, that is what's kind of included with the purchase of the equipment, which is on your second page, bottom quadrant. That's where our grant comes out. So it's a $50,000 model there, setting up that foundation and getting that cart and system. Now, your estimated initial cost is what it looks like to start up a new program, for them to come on site to do the training with whoever's going to be working in that program, making sure all of our stuff is set up correctly and those sort of things. That's for the initial program. So this is if we just did pulmonary function and that sort of thing. If we were to do another one at the same time, so they don't want to come on site twice, obviously they've already done the firewall analysis and that sort of thing, so those prices start coming down with the additional
Okay,
services.
so we're looking at some price over, a little bit over $10,000.
Yeah.
Would be, what we would get, to get into, say,
To get into
pulmonology.
Correct.
Say, which we are going to need, because we need your medical directorship.
Right, you need a medical director, you should have a medical director who's a pulmonologist, and then you want his services to interpret your PFTs, and then if we do exhale nitric oxide testing, things like that, he's able to interpret those tests for the providers. And then
Okay.
he's also able to help them if he's got a specific question.
Right, and so we're gonna need one of those anyway.
Yes.
All right,
So they would provide that pulmonologist, that?
Yes, and they've already identified, and the nice thing, that was kind of exciting about this pulmonologist too, and the nice thing about their location too in Nebraska, if like Marty wanted to go meet that pulmonologist and get that kind of relationship and comfort level, then we can provide that. But this one is known for starting up occupational health programs. So that was something else we were kind of excited about, because if we knew somebody, because we could say, hey, we know St. Francis is using this one in Platte Valley, they will go to that person and start that conversation on how to facilitate telemedicine with that. So if we know there's a provider we wanna go after, Brian Telemedicine will do that for us. So if Marty has heard great things from St. Francis about the individual they work with out of Platte Valley, we can go down that route. What interests us a lot with the one that they suggested for what exactly we were doing here, because of their reach and all the providers they can kind of recommend, the one they were looking at has, his kind of niche is startup programs and occupational health startup programs.
And Marty has experience with that as well, so this should be a great relationship, so.
Tara,
At the
are
last,
any-
go ahead, go ahead.
I'm sorry, are any other startup costs, cost report?
Yeah, so that's a good question. So for your cost report, the $50,000 equipment would run through the cost report, not just the 5,000. So you're going to get the reimbursement on that. So that's always an exciting thing when we can get grants and things, is the equipment becomes our asset. So the whole piece of equipment starts depreciating and is an asset of ours, and am I stating, I got it, okay.
You are correct.
Checks and balances here.
You are right.
So that's always a nice thing, is cost report and how it affects our income statements and balance sheets and all of that is at the full amount.
But that covers the rest of the costs, right?
So,
There you go.
that's kind of a nice thing. So that mammo thing that you guys looked at earlier, that didn't talk about that, you also get the cost report and that, but.
The nice thing about that too is the depreciation starts
Okay.
immediately when it is in service.
Okay.
The first time you put it in service.
And what is the depreciation, 5 years, 7 years?
It depends on I don't know on this one.
On the
It
top,
depends
yeah,
on,
we'll
yeah.
look at the best practices for us.
They could probably
Technology's a
have it
little
here tomorrow,
different.
so we can get a little depreciation for this fiscal year.
Yes, Ted?
After last month's meeting, a presentation, I called my doctor's son, he's a Gary community. I asked him about this. He said, it's a great tool, additional tool. He said, your providers have to be on board. He said, that's very important, the provider on board.
Yes.
And he said it can be costly if you don't get any billing done, and he suggested, and looks like we've already done some of that, is whoever's involved here, go to a facility that's already on it and see how it works, how the billing goes and everything. He said it's very important. It can't be costly, but it can be very
It is,
good.
and telemedicine is not gonna be the huge money generator. That line item is gonna probably be a cost center. It's gonna be feeding sleep studies and PFT tests to Marty. It's gonna be getting, like, Tim said, the high dollar labs for rheumatology. That's where and it's a service to our community. It's our patients not having to travel all the way to Lincoln, or all the way to St. Louis, or Denver, or for some of these specialties that we can't even get in Kearney and Hayes. So it's really providing that service. If we wanna get into those things like ears and throat or dermatology, some of the ones that don't really cycle out a ton, but we want our patients not to have to travel.
The other thing you need to look at is growth and retention. We've got growth going, and you've got to retain those patients. If you don't provide the service, they're gonna look someplace else that does. And then they're gonna start slipping away. And I learned a long time ago from a doctor in Morton County. He went when they was about to put the chains on the doors, a long time ago, and he says, I'll make a deal with you. You let me help you build this hospital up, and I'll be your doc here, and he was a surgeon. He says, we're gonna have the best equipment, we're gonna provide the best services of anybody around, and that hospital grew like crazy.
We don't have to make up our mind tonight on that, do we?
I believe it is up for a vote, yes, if we wanna accept the grant and the equipment. Yes, the grant is running out, so they've been very, very patient with us. As you can recall, Shane's been out here to visit with you, and that. So, and like Rex said, they do have a waiting list of hospitals that would like to go in on this alliance. And our regional is, I believe, one of them, so.
Well, I got the phone number of the guy that started this all, so I can call him and talk to him.
There we go, if you have any problems, we'll definitely
He
utilize
came to
that.
see, he came to see you.
Yep, sure did. Sure did, Dr. Bozart.
Yep.
Any other questions about it?
The one thing about this here is just like a Vera. This thing costs you $6 an hour for every hour you're on it. You're 24 hours a day, you're on it all the time, so that's a fixed cost in it.
If we got that one program, that's not like for outpatient or for
No,
pulmonology or any of that.
$6 an hour just to be hooked up to telemedicine.
No, that is the cost for, if we have like the Avera-like system, that is a $6 an hour charge. This is a totally different, pricing model.
He told me, Tara, that it costs $6 an hour for you hooked up to it.
Right, that's the emergency room push.
No, that was not the emergency.
Right, so and I can show you that quote as well, I don't have it with me. But this one, here's your costs, and you're gonna have your monthly fee for all your PFT readings and all of that. Your inpatient reading one was the $6 an hour, and then there's a consultation fee of the $2.90. So the inpatient type where they're on demand is where the $6 an hour is.
Tara, if we were to go to something like this with this company, would we then eliminate Avera out of the emergency room? Or do they work simultaneously, I mean, do they work side by side in complementary?
That would be a totally different conversation. They have capabilities of emergency room assistance and coverage and things. It's different than the Avera model,
Okay.
but they do have some support systems and things, but that would be,
Because
something
this
that
is
we
a
would-
card, because this is a card and can be taken around to various
Yeah.
locations, it is different than Avera.
well, the capabilities are different. What
Right.
they offer versus what Avera offers, there's different,
So, in other words, we're not gonna
services.
do away with Avera.
not right now.
Because they don't do charting for nurses, right? That's the,
I mean, there's lots of
The
things that they
major
do for
thing
us,
that-
but yes.
How long is that contract for Bear? Is that a 3-year commitment too?
Well, it has an out clause, so, but
That'd be something we'd have to do, the cost benefit analysis type of thing, would there be cost savings, and then, obviously, I know we have providers who are very passionate about Avera and what it offers, we have nurses, we have patients who are very passionate, who've experienced it, but then there's also, like I said, there's support services that this does offer. I don't know all of what it offers to say which one would be a better investment or a better option for us, I think it's looking into that, looking at what our providers need and
But we
feel.
could keep Avera and the
Yes.
card system as long as we kept our program of the card system to what is actually a starter program.
well, we wouldn't wanna do both of those in the ER.
No, I'm not talking
No,
about that,
yeah,
because
you
the
could
cart,
have-
because the cart, you can take it anywhere.
Yeah.
So what I'm saying is we keep Avera, we
Yes.
do this cart system, but we maybe agree to a startup program level and work our way up, as it were.
Exactly, so right now we're just looking at accepting the grant and getting the equipment in. Most likely because we know we have PFT equipment coming, we know we have the person here doing those, we really need medical directorship.
Right.
Pulmonology is a really good place to start, because we have a time-sensitive need for it. Looking at other ones as well is what we need to do, looking at, I mean, there's thousands of things they offer. If we want somebody who does, admitting, or on the weekends, or does the transfer and accepting and spring back, there's so much that they can offer, but it's looking at, does it fit our model, our needs, what do our providers prefer? I can't answer that, so it's looking at that a lot deeper and getting input from the actual patient community. I know we have a lot of patients that are pretty passionate about the safety net that Avera offers, so does this have that same safety net? our providers as well. As provider bases change, different ones have different usages of the Avera system. And our nursing staff, what are their comfort levels? And we just heard a little bit ago that Vicky's challenging her staff to always push that button and utilize it. So is that capability what we need? So that's a different discovery.
So can you, for instance, continue to do your probing and investigating and research, and maybe next month, give us an example of a basic dollars and cents, nuts and bolts presentation?
I thought that's what we just heard.
I will,
Well,
the emergency room,
it's
Avera is about
legit.
$12,000 higher than the Bryan Healthcare Emergency Room solution.
$7.33 a minute, I got the
Okay,
exact number.
that's,
So that gives
So
you
that's
the-
the difference,
that
but you do get
$1.33.
nursing care, the charting, the calling, the everything else. I mean, we talked in the provider meeting about the differences, and I think this, I mean, otherwise you'd have to hire another nurse, and you couldn't hire one for that price to be more focused on the emergency room. I mean, we'll continue to look at options, but, I mean, right now, we just need to decide we're gonna take this grant, and we just, the minimum amount, we can grow, we'll bring it back to you, we're not changing a barrel, we're not doing anything right now, except just, do you wanna take advantage of the grant or not?
Are you ready?
I'm ready for
Okay.
anything. I just woke up.
I think considering the medical directorship, that we need to get the PFTs back for places like Camco, and our emphasis on pulmonary, which has been a year of progress and getting Marty here and getting that program going, we need to follow suit. And so I move that we accept the grant and then the setup, which will be a startup program to get pulmonary help.
Been moved and seconded that we accept this grant. Any discussion, anybody got any more questions about it, or one more understanding about it or anything? Are we ready to vote? Everybody in favor, raise their right hand. Motion carried. Yeah, we'll spend money.
Yeah, I know, but that cost report thing sounds good.
And we gotta keep up.
We do have to keep up. We need to, if we're gonna have to get medical.
No.
New business, let's move on to that.
Board goes through the cost report.
Okay, all right,
Oh, this is it.
everybody knows, well, we have some new board members, so we make sure they know that we are part of the wellness center. We give a donation every year to the wellness center. So therefore, you folks are welcome, all of us are welcome to go and exercise, and we're encouraged to do this, okay? But amongst us, I want you to know, for the last year, we have to sign in and whatnot, and so they've been keeping track of the all-stars that were in and out, exercising and whatnot, and we have an all-star amongst us. And he deserves an achievement award.
So you
And-
checked to make sure it wasn't, I
And
didn't cheat.
he's been there for 204 times last year. So, we need to follow his footsteps, and he's getting an award now.
Well,
And, so thank you very much. And what really gets me, if you've ever seen him exercise, he's very focused and he's sweating, he just works. And then you'll walk, like right now, he walked around with 3 cookies on his plate, he always has dessert, and nice and
Yeah,
slender.
Stan made a comment today, though, I'll be watching that. No, thanks so much. I just wanna lead by example, and we needed to get people out there, so. I'm kinda like the Royals, though. This'll be my one and done. I won't be back. I was focused to finish the year. I finished, but if Matt had been here all year, he would've beaten me by 15 days. And then we've got Katie Van Allen.
Yes, he's got
And
some
then
good
Marty's setting a pretty high bar, so I won't even get a bronze medal next year, but I will cherish this always. I
Okay,
promise.
so thank you very much.
Not tax credit.
I've always wanted to do that. I really have.
forgot to thank your mom.
Yeah, they don't know. Tax credit. will start.
I just sat down, you can take it.
We would like board direction and permission to move forward with pursuing tax credits to help offset the CT scanner. I think there's about $250,000. I mean, it's competitive, there's no guarantees. But we would have to, I think the submittal date's in May. So we would bring something back to you in April to review, but we didn't want to get too far out there if that's something the board wasn't wanting us to do. You know, the tax credits, they changed a little bit since, I know I was at Osborne, we had a bunch of them left and we had to scramble towards the end to get them sold. And I think some of them were, a lot of people in Phillipsburg bought them, if I remember correctly. But if they're not, used to be, you could take, you get a deduction with state income tax, but you could take all of it off on your federal income tax. So some people, at least they said, made money on buying the tax credits. So that is, I sent the IRS, in my understanding, he's closed that loophole, so it's not as attractive as it once was. But if we could sell them all, we would like to go forward and talk to the banks and see what their interest level was. But, you know, there would be a possibility that would help offset the majority of the cost for the CT scanner. And it appears that items like a CT scanner, we'll be able to do a lot more test procedures, things than we are able to do now. I mean, Mildred's pretty, I really like this. Mildred's pretty, she's pretty, she's nuts and soup. She doesn't get too excited, but she saw the presentation, the Siemens presentation of the things we can do. She's pretty excited. So this would be one option. I think we'll be able to make a strong business case, but obviously if the tax credits would work and we would be awarded tax credits, that makes the whole thing work better. So Tara, Crystal, anybody else?
Now, the machine that you're looking at, talk to us about that.
Yes, well, I've got my notes right here, so just let me pull it up. Actually, I'm prepared sometimes. I'm really excited about it. So you saw in your capital equipment sheet, it was a $500,000 machine. Rex and Rebecca and Mildred have worked really hard to find a group purchase that would get the CT scanner for $290,662,000. It would also include DEXA scans, which our providers have been begging for DEXA capabilities. So that would give us a second piece. And then it would also include an ultrasound machine in that group buy for $70,000, which that runs $85,000 to $130,000 usually. So that's a great discount there. So for $361,000-ish, we'd be able to get all three of those. Our service agreement on our current one, it's an old machine. We probably will lose it after this year. It's running at about $64,000 a year. What that covers is if a tube goes out on our CT, which is very old 16 slicer, that's $250,000 right there. We probably don't want to put that kind of money into a 10-year-old machine. So you would get some of those things that you always try to get, years of service agreement free, good financing on that and that sort of thing. Our table weight limit would go from 300 to 500. We are having to send patients away currently due to that table weight limit. So that's exciting. One of the scans we do, Mildred said they tested it and it went from, we do it currently at 60 seconds and they were able to do it in 8 seconds. So talk about, and that also means less radiation. So you're getting about a third of your radiation exposure because of that. There's a lot more CTA tests, couldn't tell you what that means. I wrote it down at the time, but what Mildred said is other hospitals in our area can't do it. So she was really excited. That competitive streak came on that. So. And then of course we'd be able to run that through the cost report and see how that would affect. So tax credits could help offset that. It'd be a good thing there. So that's kind of what I know about the CT scanner project so far, but Rex knows much more than I do because he's really working well on getting that pricing structured.
Yeah, the ultrasound, we have 3 bids in for the ultrasound machine, and this is by far the best bid. This Siemens opportunity, again, the reason it's so, it was $600,000 2 years ago, so now it's down to $290, but grew by, and plus, there's been some changes in technology. But this still is light years ahead. It's 64 slice as opposed to 16 slice, so that is huge, and you can market that. So, again, I'm kind of excited. I don't get excited about doing business pro formas, and Tara's handling this, but This one I think's it will really look good when you take into all the factors, the cost report, the possibility of a tube going out, you know, possibly tax credits, some other things. So it would be, and we would have to change the room, do anything differently with the room, and your annual service agreement's less than what we're paying now, obviously, because you have newer technology, so.
And from the EMS side, when I was in it years ago, I remember transporting people to Salina because of the obesity, so what a guess.
Well, this would be the best in the region.
And we need DEXA, providers need that, and we want an ultrasound machine, it's like, oh my
And we do have
gosh,
a
I am
unique
very
thing
excited
too,
about this.
where, Dr. Weisinger, if you guys recall, was a radiologist before he went to medical school. So
Well, he was a radiology tech.
yeah, sorry. But so he has some great questions about it. He's working with Mildred to make sure it really does answer the questions that they have on different tests they need and stuff. So we're so blessed to have somebody with that kind of knowledge right here that can ask those questions and do that type of research on it, so.
It seems to me that the tax credit thing would be a good, I don't know, informational base to use in the community too. People pay attention to tax credits, and even if they don't buy the credits, I think that information is going to be used in the community that, oh, we're going to have such and such a thing. And I think that kind of services, that hits a lot of people who have to travel for those sorts of things.
What happens if you don't sell all the tax credits?
Well, what happens if you don't sell the tax credits, you don't get the money, and then it creates a black eye for you in the future if you try to go get tax
Doesn't hurt
credits.
your credit rating?
Doesn't hurt your credit rating, but you probably don't wanna apply for tax credits anytime in the near future, cause you've demonstrated you can't sell them. And, you know, in Osborne, when I got there, they were like 30%, see, when did I think I started in March, they were 30%, no, it wasn't then. Must've been the summertime, we were only 30% sold, and so we had to scramble, cause we had the December 31st deadline. We got them finally sold on December 30th. And I was gonna wait, cause I wanted some, but somebody beat me in, and I was gonna wait till the end to see, and we finally got them sold, but it was right to the wire, and we were taking them all over the place. So I think it'd be easier in this community, obviously, but you know, if we're committed to it, we really have to be committed to it. That's why it's important, I think, talk to the banking community, see what their interest level is first.
Yeah. Is the selling period fiscal year or calendar year?
Calendar year.
So we only have.
Now, you only have 6 months, I think, I think that's right.
They grant, so we need to send our email of intent kind of now, and let Brenda keep working on it. She's really spearheading the research on this. And
Well,
then,
she's familiar with it too.
yeah,
She is
and then in
familiar.
May, we do our official request, and then in July is the rewarding period.
And we have until December 31st.
I don't know
I believe
that.
that's right. So we really are gonna have to scramble.
Do we have any process?
You gonna go for the full amount of this,
Yeah, 250.
CT scanner?
Well, you can, it's
The
capped at
max we can
250.
do is 250.
Well, and credit to Kelly, I mean, we talked about this last year, and we weren't sure the funds were available, and we got started late, so, I mean, again, it probably would have been on the radar screen otherwise, so, but, anyhow, something, just another option to hopefully bring state-of-the-art, leading-edge equipment here and make help our providers do what they do better, so. You wanna say anything, Tim, about it?
The technology and the advance that they've done in CT scanners over the last few years has made a huge difference. A lot of your trauma situations anymore are a head to tail, basically from your head to your pelvis scan immediately on major trauma. Your older machines, the tube heats up, which takes the life out of your tube. It also takes a lot longer to do them, to where you can do a body scan, you know, in a minute or less, to where it's taken a lot longer in these older machines. Plus, the lack of ionized radiation that you're getting because of the quicker scan. So there's a lot of benefits with that. The fact that we've seen in Osborne, we didn't really think that we would order as many sonogram tests as we did, and the numbers just continued to rise. Once we had a machine full-time in-house with a great technician that could do sonograms, our machine was busy and our numbers continued to climb, which was a great reimbursement rate. She then went for her 2D echo to get heart scans, and it continued to grow from there. So you're getting a lot of good technology for growth.
And Philza just took her certification, so she's ready to go with the new piece of equipment, so. Yeah, I forgot you were there at Osborne. How did that go, Tim? There were some other issues there that were thwarting our efforts, I think, but
Yes,
we got her done.
there was.
That's tax credits, so, I mean,
The other
nodding
thing
of the
is,
head, go ahead.
is this not a capital improvement, or you would get depreciation off of the capital improvement also? So,
Well, honestly, I never thought this piece of equipment would ever be this, I guess, affordable. I don't know what other word to use, that's a lot of money, but, yeah, it's a good opportunity.
She wasn't gonna get beat out on this deal.
No, and the only deal, I guess full transparency, the only caveat is we will have to be a site where people can come in and look at the equipment, but I figured that was probably worth it. And I think that's a good opportunity to
Good publicity,
see, show what we got here, so.
good publicity, good exposure.
So move forward, nodding in the heads with the tax credits.
Yeah, check it out.
Okay. So you'll tell Brenda tomorrow?
Crystal?
Well, I guess that's right.
Brenda, your favorite tax credits is.
No, she's, yep, she's very, yeah, she has connections to it,
Yeah,
so,
she does. She should.
which will help us.
Anything else? How long we got on this machine you're talking about? Another month, don't we?
Which one? Oh, for the pricing, we have another month. Ours, that we have now, hopefully more than that. Yeah, Vizient was, they don't like to extend group buys, but they were willing to extend it, but they said you've gotta make sure Siemens is willing to extend it. So, we did get that confirmation, so, but it is only through April, whatever, it is, our board meeting on the 24th. It's through 8 o'clock, April 25th, so I'm supposed to call them first thing Friday morning, so we have a lot of work to do between now and then. And the way the tax credits work too, we can sign a letter of intent, we work this out with Siemens as well, we can sign, if this is where we go, we can sign a letter of intent, but we can't take possession or make a payment until the tax credits, until July 1st, I think, right, or whenever the tax credits are awarded, so.
Yeah.
I think we've got all that worked out too, so there's some logistical things we have to make sure we don't get ahead of ourselves either.
In other words, then we can't take the machine until we get the tax credits sold.
Well, are you gonna be able to get tax credits? We will be able to sign a letter of intent, have it locked down, and I don't think from the proposal, if I remember right, I don't think they were planning on installing it till July or August anyhow, because these things, I mean, as affordable as they are, there's a backlog on them, so.
Obvious question there, does that increase the taxes for the people in Phillips County?
this too.
No.
No, not as long as everything goes, it's fine, nothing goes
Yeah, I didn't know
bad.
where that played in there, not okay.
No, and I really do think this is gonna be one that'll be pretty obvious, that it's a good decision, or it'll be obvious it's not, but there's enough, I mean, we're not gonna be able to offer CT scanning services probably past next year, or we're gonna be at risk every day, people aren't gonna sleep well, cause we'll have to come up with $250,000 to replace a tube on a bad piece of equipment, or we're gonna have to go out, and now we're gonna have to get a CT scanner, whether it's not a group buy, and it's gonna cost us a lot more than that.
And we have replaced a tube, and the current one, luckily, we had the maintenance contract to replace it. So
I've rolled the dice 3 times in my career, and 2 times I've lost on tubes.
She was on dual.
Well, one thing I'm not getting clear, Rex, I'll be right honest. Okay,
100 milligrams.
if we're going tax credits, we can't take possession of the machine till we get the tax credits approved, right?
To the external rack.
Then we gotta have the tax credits sold before we can receive the machine, right?
Well, I think we talked about this today, we have to make the business case that it works without the tax credits. So that's the decision, the job we have is to prove to you that it works without. If we get the tax credits, great. They're not gonna be able to deliver it till July or August anyhow, so the delivery thing's not an issue. And if we get the tax credits, we'll celebrate and know it really worked well, and, I mean, that makes the whole, financial equation look better. If it doesn't, we're gonna have to stand on our business plan that it works. So does that answer your
Yeah,
question?
the timeline
Answers
is,
my question, but okay.
Rex, do the banks help us to sell the tax credits to their?
They did in Osborne, didn't they, Tim? Didn't the banks help sell the tax credits?
Didn't the banks help sell tax credits,
I thought
or some of the CPA firms?
CPA firms did.
Yeah,
And I made a couple trips to Wichita and, we traveled all over and dropped our little brochures all over the place, so.
I would think that Dennis Miller or Lee.
Dennis would be
Some
helpful.
of the people that are CPAs.
Well, we'll work on that over the next, we'll work on that before next month, but again, our job is to justify this without tax credits. If tax credits work, then that's better.
And tax credit's a good thing, if we get into it, it'd be a good tool for on down the road too.
And we're only asking for $360 in tax credits?
We can only do $250.
Oh, $250. Oh, well, that shouldn't be that hard to sell.
That takes care of all the 40,000 of the
Sounds like cricket wants them all.
cricket. That's it.
Any other business?
So we're looking at an executive session? In how much time?
Let me have 10 minutes first.
Okay,
Just before.
just the board, okay. I move the board recess to an executive session pursuant to KSA 754319B1 for the discussion of personal matters, non-elected personnel. And that the meeting, should we give them 5 minutes to clear the room and
Yes.
whatever? And then the meeting after 5 minutes.
9:05.
So we'll start at 9:05, and we will come out at 9:15. So, thank you, everybody.
Who you want?
Who's gonna stay? Just the board for this first time.
It's been nice
First 10
seeing you
minutes.
again.
you too.